Everyone, I declare open this public hearing being held in Canberra of the House Standing Committee on Health, Aged Care and Sport for the inquiry into health impacts of alcohol and other drugs in Australia. I remind all present that as Chair I'll ensure that the proceedings are conducted in an orderly, respectful and courteous way. In accordance with the Committee's resolution of the 4th of August 2022, this hearing will be broadcast on the Parliament's website, and the proof and official transcripts of the proceedings will be published on the Parliament's website. I'll just add that if you are going to give evidence that you would prefer to be held in camera, we're happy to do that, but that would mean we'd have to clear the room. And secondly, if you are going to make adverse comments about an institution or a person, it may be better to consider giving that evidence in camera. And we would prefer, if that were to be the case, that it definitely is in camera, but that's your choice. Good. I now welcome the witnesses from the Foundation for Alcohol Research and Education to give evidence today. For the Hansard record, before giving evidence, would you please state your name and the capacity in which you appear before the committee. This hearing is a legal proceeding of the Parliament. The giving of false or misleading evidence is a serious matter and may be regarded as a contempt of the Parliament. The evidence given today will be recorded by Hansard and attracts parliamentary privilege. I'm joined by Dr. Michelle Anandaraja, the member for Higgins, and shortly we are joined by Ms Jenny Ware, the member for Hughes. I'm going to open this meeting as a subcommittee. I now invite you to make a short opening statement before we proceed to discussion. And thank you very much for taking the time to give evidence today. Thank you.
Thank you.
Who would like to start?
I'll start if that's okay. I'd like to begin by saying thank you to the members of the committee for allowing me to share my son Dylan's story. Mm-hmm. Dylan was only 26.
Could you just state your name?
Sorry, my name is Rachel Allen.
And the capacity in which you appear?
Rachel's a lived experience.
Yeah, lived experience.
Great, thanks.
Okay. So to continue, Dylan was only 26 when alcohol addiction took his life in April of 2022. While growing up, there was no way of knowing that Dylan's life would be cut so short. He loved his family, had a number of interests, and was overall a well-adjusted child. However, once he was about 14, it became evident that he was struggling at school, with the end result being that he would actually leave school. The culmination of these events led him to become extremely depressed, and his anxiety was also severe. At this time, he was looking for a way to manage his mental health problems, which coincided with his introduction to alcohol. Some of his peers were experimenting with alcohol, and so he did join in. And I guess that's a very common thing to do, but the initial relief he received by drinking alcohol reinforced his desire to continue drinking. In his adolescent mind, and I do want to emphasise he had an adolescent mind, Dylan had found a way to manage his mental health issues. I understand this is because initially alcohol works to increase dopamine receptors. However, after long-term chronic use, more and more needs to be consumed to gain the same effect. I recently actually heard this referred to as alcohol-seeking behaviour. Now in his early 20s, he was completely, and I mean completely, incapacitated by his alcohol use disorder. So you've got to imagine someone as young as that, please. Sadly, sorry, it gets emotional.
Sure. So you take some time.
Thank you.
Have a sip of water.
It's going to get emotional.
It's okay.
Sadly, around this time, this is one of the worst things, but he was also completely socially isolated. The isolation, I sometimes used to wonder whether the isolation was worse than the alcohol. It increased, again, compounded and reinforced his need to drink. Emotionally, it nearly killed me. when he would say things to me like, "Mum, please don't ever leave me. You're all I've got." By this stage, I would describe him as being imprisoned, completely imprisoned by his addiction. He hated waking up knowing what he would have to go through each and every single day. More of the same, having to seek out alcohol, having to go through just that process, feeling like he had quite a meaningless life. By 25, Dylan was aware that he was losing the fight with this alcohol addiction. He would say things like, and I do quote, "I finally hit the wall, Mum. I'm screwed." Reflecting back, Dylan repeatedly fell through the gaps in the system. He engaged with alcohol services, so many. He attended several rehabs, and he was always at the GPs. And I wanted to monitor his health, because I did do a lot of reading, and I did know to some extent what was going on with his liver. I knew that by this stage it was quite inflamed. He went through years of stigmatisation, even would you believe, by quite professional people who you wouldn't consider people that would stigmatise him. But I want to also emphasise this was his experience. This was his experience. Tests that should and could have been performed to prevent his liver going from compensated to decompensated were rarely performed. In terms of community mental health and mental health facilities, he was overlooked due to his problems being considered purely alcohol related and not mental health related. Although it was profoundly evident that his alcohol misuse was associated with his mental health, it couldn't be separated. He was assessed as not at risk, meaning he wouldn't be admitted to hospital. I do want to also mention that there were 2 GPs that tried to have Dylan sectioned, and that was overturned at his mental health facility. When he did finally present at his GP's with end-life liver disease, which wasn't recognised as end-life liver disease, tests again were not carried out, potentially life-saving, so he had 2 months at that time. He was given a referral to a gastroenterologist at the hospital, but it was never considered urgent. It wasn't considered an urgent case, even though when he was examined by the doctor, he couldn't even cope with being touched, like his liver. He hadn't eaten for over a week. His toxins were clearly visible, and his eyes were yellowing. So 2 weeks went by where something may or may not have been able to happen. So me and my 2 girls, who were very involved at this stage, in fact they'd been involved all the way along, but they both, one was doing uni, one worked full time, so they did what they could when they could, to support Dylan. Came with me and Dylan to St Vincent's Hospital. Even then, as sick as that he was, he couldn't leave the house without the security of knowing he had alcohol with him, if you can even imagine that. Tests conducted confirmed my worst nightmare, that Dylan had a significant liver injury. So he had the scans, significant was one of the words, liver injury the other. Regardless of this, we were told by the RPA team, and I'm only speaking factually here, that he would not be considered for a liver transplant based on his history with alcohol. So lots of things around his history took priority over the fact that he was only 26, and sadly that he could have turned things around. It was just not even considered. Anyway, it feels surreal, the whole thing. But right at the end, as a mother, that task of going back up to palliative care where he only spent 1 day, and seeing his body laid out, and it was just yellow, and I remember thinking, he looks so young. How could somebody so young have lost their life to this hideous disease? It still feels surreal, the process of picking out his casket and choosing the clothes he would wear. The pain is still, as you can see, inconceivable. But unfortunately, this was my reality. And so he can't speak, obviously, and I just need to be that voice now for him and for others, because this does affect not just men, which is the stereotype in their 40s and 50s. This is affecting young people now. And he was really adamant that we considered warning people about the effects of alcohol, because he couldn't see why this was ever disregarded as when it's been picked up by the tobacco industry and everything. Anyway, that is the case, that it was it has never been it's not being put on alcohol as we now know, and as we know, and he always felt that it had the potential to save lives. He did strongly promote that, and young people, he felt really, especially young, because he was young, felt they did deserve to know the health risks, as we do with cigarettes. He couldn't distinguish what's the difference between knowing what alcohol can do as opposed to what cigarettes can do. It's insanity that it's not on there already. But I just want to kind of conclude by saying thank you to the committee for taking the time to listen. I'm genuinely grateful to have had this opportunity, and I'm so thankful to be here. So thank you so much.
Well, thank you very much for giving your evidence. Obviously, it is very harrowing for you, and we are going to ask you some questions. You don't have to answer the questions if you feel they're too personal, but thank you very much for coming along today. Do you want to make any comment, Katerina?
Yeah, I might just make a brief statement if that's okay. Yeah. So I just want to acknowledge Rachel and the story that you've just shared many times now in the Hope for Change. So my name's Katerina Georgi, and I'm the CEO of the Foundation for Alcohol Research and Education. I want to thank you for the opportunity to appear, and I want to start by acknowledging the traditional owners of the lands that we're meeting on today, the Ngunnawal and Ngambri people. I want to acknowledge that Aboriginal and Torres Strait Islander people are disproportionately impacted by alcohol harms, and the many Aboriginal and Torres Strait Islander leaders who are driving change across the country to address this inequity. I just want to flag that I am sitting beside Rachel today, which I feel very privileged to be doing. And following us, you'll hear from Sophie, Angeline Bruce and Jessica Birch. You'll have also received submissions from James Brett, Trevor Royals, Kim Valentine, Catherine Elliott, Stephanie Taylor, William Spall and Rodney Holmes. I want to acknowledge each of these people because they're sharing their lived experience of how alcohol has negatively impacted their lives, and this isn't easy. There's a lot of stigma that exists around alcohol in our society and community, and it creates inordinate barriers for people to engage. Increasingly, decision makers are asking for people to share their experience in an effort to understand, and each time decision makers do this, we're asking people to reopen wounds, and you're raising expectations and hope. And so when you make this request, it brings a responsibility to act, and we feel strongly a responsibility to Rachel and others who are sharing their lived experience. Every day, people across Australia are negatively impacted by alcohol. At this very moment, we have the highest rate of alcohol-induced deaths in 2 decades. We've also seen upticks in hospitalisations and alcohol treatment episodes, which have not returned to pre-COVID levels. 1,742 people lost their lives from alcohol-induced deaths in 2022. And to put this into perspective, this is higher than the number of people who die on our roads and higher than the number of people who die from melanoma each year. When you consider all alcohol-related deaths, the figure jumps to 5,000. That's a person every 2 hours. The harm from alcohol also ripples through our families and communities. We know that alcohol increases the risk and severity of gender-based violence and violence against children. So 1 in 6 children are harmed by alcohol, and these children have been verbally abused, witnessed violence, physically abused, left unsupervised, or experienced financial abuse. These harms don't arise by accident, they occur because systems are geared towards driving this. We live in communities where alcohol is available very early in the morning until late into the night, and it can also feel like there's an alcohol outlet on every corner. A really important point to make is that the expansion of data-driven marketing means that people get pummeled with ads online, and the delivery of alcohol means that every phone is a bottle shop, and alcohol can be sold by companies into a person's home within 30 minutes. Alcohol companies sell 36% of alcohol to 5% of people. With this new model of marketing, they can now reach this group of people in a way that wasn't possible in the past, continuously targeting them with predatory promotions. This makes it impossible for people who are wanting to cut back to escape. We've had women share with us that the sound of an alcohol delivery truck is the prompt for them to enact a safety plan to keep their children safe. We've had family members share with us that they've had a loved one who was delivered thousands of dollars of alcohol to their home right up until their death. And I've even been shown images of whole rooms filled with empty boxes of well-known alcohol retail brands. And this is all possible because we don't have sufficient safeguards in place to protect people from harms. Our state and territory alcohol laws have not been substantially changed for more than 5 decades. They focus on building business ahead of harm reduction and contribute to rising levels of inequity and the overcriminalisation of people who are most vulnerable. Rules around marketing are left to companies themselves, and they are found to often have disregard for them. Services are woefully underfunded across prevention, early intervention, treatment and support. But change is possible. I think in these roles you have to have hope, and I'm given hope by the change that we're seeing by some governments across the country. So in September last year, National Cabinet agreed to review state and territory alcohol laws to make sure they're best practice in preventing gender-based violence. The South Australian Government is already consulting on a bill around this, and the ACT Government has committed to a comprehensive review. The Australian Government has partnered with FARE to deliver Every Moment Matters, which is a campaign on alcohol, pregnancy and breastfeeding. This is a world-leading campaign that's 3 years in, and it's increasing awareness and changing behaviours. And every dollar spent on the campaign is resulting in a $9 return on investment. And the Australian Government has also made a commitment to develop a framework for the prevention of alcohol-related family violence, which was a recommendation from the Rapid Review of Prevention Approaches for Gender-Based Violence. These are all positive steps, but there are also areas where governments are taking backward steps. The lobby group representing commercial television stations is proposing to extend alcohol advertising by up to 800 hours a year, largely in children's viewing times and at high-risk times on weekends and public holidays. Because of our flawed alcohol marketing laws, the lobby group themselves are tasked with consulting on the proposed code and drafting the final code for consideration by ACMA. The Northern Territory Government has introduced a bill to remove a minimum unit price for alcohol, which is being debated next week. This is being done without meaningful consultation with the community, and if passed, it will remove an effective measure which is making a difference. It is no coincidence, perhaps, that the Chief of Staff to the Chief Minister just left his job as the head of the alcohol industry lobby group in the Territory. This revolving door is one way that commercial interests influence policy, but there are many more. The Parliament's Register of Interest shows 1 in 4 federal politicians have received a gift from an alcohol company or lobby group. The most recent disclosure from the Australian Electoral Commission revealed that companies that profit from alcohol donated $1.8 million to political parties in 23-24. But their influence goes much further than this. When these corporations are ever present, it creates a cloud of influence hanging over decision makers and fosters a general assumption across the public service and among politicians and advisors that certain issues are out of bounds. There are also just straight out terrible behaviours by some companies, like the biggest alcohol retailer in Australia fighting to try and build an unwanted alcohol megastore near dry Aboriginal communities in Darwin for 5 years. Or an alcohol lobby group's opposing pregnancy health warnings and then claiming to take the scalps of senior public servants once they're adopted. Or the largest alcohol retailer boasting of how their sales increased by 26% on the first night of State of Origin, a night when alcohol-related family violence incidents reported to police increased by more than 40%. We must address this influence if we're going to make progress. So people need a chance to make a change, and we had a participant in a study on predatory online marketing, Megan, share with us. Just make it easier for people who are actively trying to change. So the cards are currently stacked against us, and this inquiry can help to change that.
Thank you very much. So I might open it up to questioning. Michelle, would you like to start?
Sure, thank you, Chair. Firstly, Ms Allen, thank you for sharing your story about Dylan. I worked in a hospital where I saw on a daily occurrence patients with alcohol-related harm, including hepatitis, which is what your son probably had at some stage, and decompensated liver disease, and it was tragic. It was absolutely tragic. It was like a revolving door, as you described. I guess my question to you is, the best time to act is at the very beginning, when he was identified as a young boy with issues. What if this movie was to be replayed again?
Yeah.
What would the best interventions look like to you?
I guess I'm just thinking of interventions. I guess the alcohol wouldn't have been as accessible. We live in, where we were living at the time, there was probably up to about 10 different outlets. I guess it's very difficult to mitigate because, you know, it's there, it's everywhere. So aside from trying to reduce harm that way, and have conversations, we had many conversations. Maybe we could have had more around the harm. I didn't also know the extent of the harm that alcohol could do at that time. So right at the beginning, we're a bit sort of ignorant to those facts, to be honest. But it was certainly never encouraged. And for a lot of kids, they just think it's a rite of passage, don't they? I mean, it's just unfortunate that, you know, there's a lot of harmful things out there. Alcohol's just one of the worst. And he picked up one of the worst ones, you know. That is, honestly, the bottom line. He picked up the one that is very hard to turn around once you become addicted to it. I mean, relapse is something like 60% failure, you know. It is, and it's never good to start young, of course, because we know that the propensity for being able to then give up is very minimal. You know, it becomes it because your brain's developing during those adolescent years. It's very difficult. So, yeah, the measures that were taken included doctors. He went to doctors. I would, I guess, encourage that. We did try over 10 different antidepressant medications. He was very resistant to medication. I don't know whether you've heard of that happening before. And then, of course, once the drinking started, it interacted. So we keep going through this cycle, you see. So I was pretty vigilant with everything, I have to say, even at the beginning. It really shouldn't have spiralled if you consider what was put in place. I just feel there are environmental factors. There were so many environmental factors that I wasn't in control of, that perhaps can be considered when we talk about, and we have looked at those, and we just need to keep looking at those. So I hope that answers some of your question.
Thank you. And a question to Katerina. Thank you for your presentation. I think there are two things that you raised. The first is that our public health measures are being undermined by corporate profiteering. That's one. The second, and I always found this hard when I was practicing, 5% of people are at high risk, right? Which means 95% aren't, presumably. And we tend to think of that 95% and we privilege them above that 5%. So in other words, personal choice, autonomy is privileged above the needs of that very vulnerable group who are going to be prone to addiction, right? So how do we as policymakers approach this? Because most people, if I had 100 people in this room, would say, I drink responsibly, I have I'm okay. You're nannying me. You are, this is overreach from the government. So how would we frame this? What kind of concrete measures would we take to maybe constrain the availability and marketing of alcohol, which I completely agree needs to be constrained, because I did see it explode during the pandemic.
Yeah. Excellent questions. I might step through. I'll start with the 5%. So that was a statistic on the proportion of alcohol that's sold by alcohol companies. So 36% is sold to 5% of people. About 75% is sold to 20% of people. And those 27% of people are still drinking outside of the guidelines. So when we're looking at higher risk drinking as defined by the guidelines, we're looking at around a quarter of people. When we're looking at people who are at risk of an alcohol use disorder, we're looking at about 1 in 10 Australians. So these are fairly high numbers, and you would start to argue then that if these numbers were as high in our road toll, if they were as high in what we're seeing with the response to skin cancer, for example, then we'd be taking greater action. And so the question then is, why is this seen differently? And there's a couple of reasons. So one is because of the stigma that we're talking about here. And that's because of that notion of individual responsibility. And that's partly driven by alcohol companies who have coined the phrase drink responsibly, and they are predominantly arguing for measures that are around individual responsibility. But what's happened, particularly in this digital world, is that there are no friction points. There's no stopgap for people. So all of the things we used to say to people, these 1 in 10 people, was try and avoid alcohol, try and avoid the triggers. But you can't avoid alcohol and avoid the triggers if you're reading your article and you're being served an ad that's made just for you around exactly what they think you'll like based upon algorithms that are telling them how you feel, whether you've sought help, and the types of things that you've bought in the past. The type of marketing that says you bought a bottle of vodka last week, let me sell you 2 now at a discount. So there are a few things we need to be doing to address these broader cultural issues that contribute to that perception around individual responsibility and stigma. So the first is around availability of alcohol. We know that things like what Rachel was talking about with 10 different stores in a local area, that does contribute to more harm. We know the link between alcohol outlet density and alcohol-related family and domestic violence. The more outlets there are, the more violence we see. And similarly, the more outlets there are, the more chronic disease we see. We know that when alcohol is available later into the night, that's when we see more harms. So suicides that involve alcohol, family violence that involves alcohol, that's all more likely to happen later at night. Yet alcohol can be delivered in as quick as 20 minutes into the home as late as midnight. So this argument around individual responsibility versus broader community has gone so far in the direction of not even putting in place any sort of community safeguards that help people to be able to help themselves and keep their families safe. It's just completely gone. The pendulum has swung in that complete direction. And so we need to really reorient that. So there's some of the things there. When we're looking at marketing and federal laws, there's a Privacy Act review that's part done and that's going to be considered in the future. Within that Privacy Act review, data should be treated as sensitive information that involves whether someone sought help on alcohol and other drug treatment or what they've purchased when it comes to an addictive product in the past. And that data shouldn't be used to market to people. We shouldn't be giving companies tools to target people based upon their vulnerabilities. When it comes to our alcohol laws at the state and territory level, when I say they're more than 5 decades old, governments might argue that they've done countless reviews, and I know they have. I've been involved in many of them. But these reviews are tinkering around the edges. Like, these laws still focus predominantly on unlicensed premises. So they still focus on pubs, clubs and bars when 80% of alcohol is sold for consumption in the home now. And so a lot of them don't even talk about marketing from bottle shops, let alone dealing with delivery. Most of them are completely silent on delivery. And what that leaves is this huge gap where IDs don't need to be checked for delivery, where people can be sold alcohol if they're intoxicated for delivery. So some common sense measures there, like alcohol shouldn't be delivered before 10 a.m. or after 10 p.m. We should have a 2-hour safety pause around deliveries, because we know that when people are delivered alcohol rapidly, so within 30 minutes or 2 hours, that 40% of them say they drink 11 or more standard drinks. So it's the higher risk level that we're talking about in terms of a business model. So having a 2-hour safety pause would mean that if people order alcohol, they can be delivered at 2 hours later and not sooner. And we know that that will then give people that friction point to allow them to pause and reconsider, which is what governments need to do. They help to give people those friction points.
But why can't we just ban online sales?
That's an excellent question.
Has it been going for a long time? Is this the problem?
It's an excellent question. It is higher risk. And if you had seen the types of pushback we get even around these measures, the types of lobbying that occur to try and undermine these measures, the work that we do with ministers over years, only to see it get to a Premier's office or a Chief Minister's office and completely torn to pieces and nothing really happens. The influence just undermines any sort of control. So we're trying to introduce harm minimisation measures that target the highest risk behaviours. And at the moment, the greatest fuel to this fire is that combination of marketing and rapid delivery. And if we can uncouple that data-driven marketing, then we really do reduce the harms there. And that's what we're focused on.
I think we should ban it. I just don't understand why we have online marketing for alcohol. We don't have online marketing for addictive drugs.
Oh, sorry,
and
marketing
alcohol is a drug.
Marketing.
Delivery. We
completely support a phase out of all alcohol marketing. 100%.
I think we should just ban the.
No, we would like
it.
to see an alcohol marketing control act that mimics the Tobacco Marketing Control Act. And we think that that's really critically important. And just to go to the point around the flaws in marketing at the moment, controls. So this example of the Commercial Television Code being considered at the moment, Free TV Australia drafts the Commercial Television Code. And then what happens is they consult with commercial television stations. And what usually happens is ACMA then rubber stamps that. Now, we're at a process where Free TV has made very clear that they have the intention to extend alcohol advertising by 800 hours on public holidays, on weekends, in children's viewing times. And they're going to put that proposal to ACMA. And so with the very limited controls that we have, we need ACMA to stop that. So I agree with you that a complete marketing phase out is absolutely where we need to be. But what we're seeing at the moment is we're seeing this all going in the wrong direction and there's no government intervention to stop that.
So you're saying things are getting worse, not better?
In some policy spaces, absolutely, and marketing is one of those. 100%. Marketing, the way that marketing is happening is evolving so rapidly and government regulation is not keeping pace with that. And at the moment, the government gives the industry the responsibility to control their own marketing. There is a Department of Health representative that sits on an alcohol industry body, the AUSParliamentLive, which gives it credibility. But what it is it's a bunch of alcohol companies sitting around a table saying that they're setting their own rules and policing themselves. Now, if anyone's watched TV with a kid, and I have a couple of them and we watch TV frequently, the number of alcohol ads that pop up during kids' shows or family shows, and we see it reported as well to AUSParliament all the time. They're popping up in The Voice or Australia's Got Talent. And the responses from these commercial television stations is, oh, it's on demand, or this isn't a children's viewing show, or children aren't watching TV. So we just have to take that from them and we need governments to properly regulate.
I might move on to Jenny. Questions?
Yes, thank you. Thank you, Chair. Thank you both for being here. Rachel, I'm a mother of sons, a little bit younger than Dylan, so I'm absolutely appalled to hear of your story, so I'm so sorry.
I appreciate that.
And I really appreciate you're very courageous to come and be advocating for him, and I know this isn't always an easy forum, so thank you very much. He would be very proud of you. I suppose the part of your story that really concerned me was the way that alcoholism had been stigmatised to such an extent that he wasn't eligible for, or that he wasn't recommended for a liver transplant. How, look, this may be a question for Katerina or one of the health professionals, but how could you see any, or do you have any recommendations as to how alcoholism, particularly in younger people, could be destigmatised within the within the medical profession so that that wouldn't happen again?
I guess, like what I've read from looking at the Nordic approach and a few other ones, Scandinavian countries, it comes under health, basically. It's addressed as a health concern, essentially. I think right now the problem is that there's this, what would you call it, Katerina? Like a school of thought or where doctors and GPs just see the addiction. They don't see underneath. It's a major health. It's a health concern primarily. So how can I used to sort of use this analogy that if Dylan had gone in with failing kidney disease, everything would have been happening. He would have been straight away up to the hospital. There wouldn't have even been a hint, a hesitation.
Or I suspect also that even if his liver disease had been caused by something other than the alcoholism.
Other than. So the stigmatisation impacted profoundly on the level of treatment that he received.
So in that case, is sort of a recommendation that you would be looking at is, I suppose, an education of health professionals to be treating. I mean, we've also sat here and heard, we've also covered gambling addiction as well on this committee, and there are a lot of synergies with the evidence that you've given today. Isn't it then? Don't we need to first of all educate or have a whole rethink within the medical and health industry around alcoholism is a disease. It is, and addiction is one part of that. In the same way that it almost seems to me as though Dylan was being blamed for his health
I even
problems.
went as far as having a look at stigma, and it becomes so ingrained, the stigmatisation, till it gets to a point where it's considered self-stigma. I don't know if anyone's ever... So in hospital, days to live, he looked at his sister and said, because she said, do you know what's happening? And he said, yes, I'm going to die. And he said, but I've done this to myself. This is what I deserve. Now, you don't understand how much that had been ingrained into him. And so, yes, of course, the stigma thing is, it's allowing it to keep repeating itself. It really does need to be addressed, because you're looking at the professionals who have so much, what would you call that? They have so much control in this space. Power. They can make decisions that are life-changing decisions. If you get a good GP who considers this other than self-inflicted, that is other than all these things that surround stigmatisation, then you will receive
self-inflicted.
Definitely self-inflicted was something that he considered it, and because it had been repeated over and over and over. And they already have so much self-loathing, they have so much low self-esteem. It doesn't take much to just tip them over the edge and say, well, you've done it to yourself, does it? And I would just like to see, the whole mindset around that, the whole way the perception, whatever you want to call it, around alcohol as a disease changed. And that's another reason I'm doing this, because I really would like to be that voice for him, be that person that just says, and for anyone who's going through this, that we get away, because it's not helpful, we get away from the self-blame, we get away from those narratives, and we try and do something constructive, rather than that's really just a way of being just, blaming the person is never helpful. But also, there's a lot of issues that come with it, like the fact that you don't receive the help and the, because of the stigma. So it seems to cloud a lot of things in terms of medical treatment and care, if that makes sense.
Do the 10 Medicare funded psychological sessions at the moment that are available, do those sessions cover counselling for alcoholism?
Not really aware of that. I know that he was receiving group therapy when he would go into a hospital, like a private hospital. Again, it just comes down to how much they, again, not necessarily willing to engage, but how much they can engage, considering the level of alcoholism, because he had profound AUD, so alcohol use disorder. So he was very cynical at this stage. It was very difficult for him to believe, sitting down and trying to deconstruct what's happened to his life. It was going to help him. He was beyond that point. Again, maybe that is something, going back to the question regarding what can be done in the beginning stages. I would say a lot of counselling, maybe a lot of psychotherapy, things like that. If you can see those warning signs there, it may be that time to look at that, because the brain, it really does go through a lot of changes with alcohol. And I've always thought it would be really interesting to hear things from a neurological perspective, because a lot of people don't realise how much the GABA receptors, neuropathways, all these things, it can be reversed, of course, but it's not always. There you go, not always. I mean, how many drugs do you know that can have that debilitating effect? I mean, they all have debilitating effects. This is almost a can't come back from effect, though. And that's what I want to highlight. So, yeah, we definitely need to look at the stigmatisation, and it will go a long way in...
I think we have to look at stigmatisation of addiction overall, whether it's drugs, gambling, alcoholism.
Of course, all those areas, yeah.
Thank you very much. Chair, do you mind, I've just got a couple of questions for Katerina around the marketing.
Yes, yeah.
Yeah, okay. Around some of the things that you'd said, and I think that, so I think we've recorded probably the recommendations that you have about looking at a bit tighter regulation or some regulation of the delivery of alcohol based on the evidence that you said is there, that the delivery of alcohol has led to a sharp increase in alcoholism and in behaviour affected by alcohol since the delivery of alcohol's first become available. In terms of the marketing, you did call for, you said that you'd like to see a complete marketing phase out. I just want to explore that a little bit with you. And you made the comparison with tobacco marketing strategies. I think up against that, there is certainly, and I'm not a doctor, I'm the only non-doctor I think on this committee, but there is there is plenty of evidence that, and we've had a very successful, I think, marketing campaign around, every cigarette is doing you damage. I think the problem with an overall ban on alcohol is that alcohol is a product that you can consume safely in small doses or in recommended doses. So I don't think I could support an overall marketing ban on a product that is legal and also that can be used in a safe way. So what's another way that besides a complete phase out of alcohol marketing, what would sort of be your key drivers that you'd like to see with some partial ban or some better regulation around it?
So just firstly on the phase out of marketing, we've been working alongside our colleagues in gambling harm reduction. And one of the things we've been working to establish is our Harmful Product Marketing Act. And we think a distinct piece of legislation is needed across the two areas, also because a lot of the companies are the same. The ownership crosses over. You can see the intersect there. We think that Marketing Act should focus on a phase out, and we think that that's really important. Now, let me speak about why on that, and then let me speak about the current legislative instruments and how they could be strengthened if a Harmful Product Marketing Act wasn't introduced. So the reason why that's important is because alcohol companies do so much marketing that contributes to the normalisation, that contributes to the stigma. So if you've got companies all the time saying the way to unwind is to have a drink, the way to end a week is to have a drink, the way to celebrate is to have a drink, the way to commiserate is to have a drink, that becomes the predominant norm. And then everyone, and doctors aren't immune to this, which is why they also contribute to the stigmatisation, starts to see this as the predominant norm. Now, if we don't rein that back, then any health promotion campaigns that governments do will always be in the face of that onslaught, that multi-billion-dollar marketing that happens by these companies. And the amount of money they're spending on hyper-targeting that and making that really sharp is significant. So one of these companies spent more than $70 million on 1 year just in building their capability in that space, not even on the marketing component. So we think it's a really key part to addressing all of these underlying issues that we're discussing today. Now, if you're saying that that's not an option, and then let's talk about the existing instruments, the issue is the existing instruments are so flawed. So the Broadcast Act covers commercial television, but not video on demand, which isn't picked up anywhere. And so you're already missing a huge part of the marketing space there. Digital marketing isn't really captured anywhere. And the Privacy Act is the only place you get to at least address the data. And then even when you're doing that, you're trying hard to put it into a framework that, the Privacy Act up until recently hadn't had any changes since before the internet. The rest of marketing control in the alcohol space is left to the alcohol industry through the ABAC. So that's a bunch of key alcohol lobby groups who sit together, set their own rules and then police themselves, but there's no enforcement and no measures. So we can't strengthen that because it's not a real thing. So a piece of legislation is needed. The extent to which that legislation goes to, or a separate piece of legislation, hence the proposal for the Harmful Product Marketing Act, is needed. The extent to which that legislation has objects that try and focus on protecting people who are most vulnerable and children versus community-wide controls is something that's often discussed. But I can tell you that it's really, without a phase out, it's really hard to protect groups who are most vulnerable, because Meta will tell us that kids don't see ads. I've got countless studies that show you that kids are pummeled with alcohol and gambling ads. And so even when they're saying that these controls are in place, they just don't work. And as for the safe level, this is really important as well. We have the National Health and Medical Research Council guidelines, and they say that your risk of dying from an alcohol-related death increase by more than 1 in 100 if you drink more than 4 standard drinks on a day and more than 10 standard drinks in a week. So they're talking about how you can lower your risk. But even they say the less you drink, the lower your risk of harm, because all of the evidence is showing that even smaller levels, there's risk associated. So there's not this no risk equation. It's just how much risk are people willing to take, which is always the discussion in health. And different activities. And at the moment, the NHMRC Council have set those guidelines of 4 and 10, but there are many countries across the world who are lowering those guidelines, and certainly a lot more evidence, because alcohol is a cause of 7 different cancer, that even at lower levels, it increases your risk of those diseases. So it's not as clear-cut and as simple as tobacco is every stick and alcohol isn't. There are these increasing risk discussions. And so it's a question of how much risk we're willing to take and how many lives will be lost and how many people will be hospitalised.
Yeah, I think you're right on that point. I mean, we educate people about road safety. And we can't just simply say to people, I mean, the safest way not to get killed on a road is not to ever be on the road, is not to drive a car, but that's not realistic. I'm just looking at, I suppose, I'm interested in, I suppose, what you could do around, what would be the minimum that you could say you could do to regulate delivery of alcohol? I mean, I've never bought alcohol on the net, so I don't know how it works. Do you have to produce some sort of evidence
For
that you're over 18?
It's a great question. For delivery, it's in state-based liquor acts.
Right, okay.
And those state-based liquor acts need a range of different things around the delivery. Firstly, there should be a separate licence category for the delivery of alcohol, which there isn't at the moment. So usually it's an extension of an existing licence. It might be the extension of a pub or the extension of a bottle shop. So if there's a separate licence category, then when someone applies for a licence to deliver alcohol, they have to assess risk, and they have to assess how it contributes to density, and they have to, so those harm minimisation processes would have to be going through, which they're not at the moment, which is why there's this proliferation. Second thing is that we need controls around, so ID needs to be checked at the point of purchase and delivery, which isn't a requirement in most state and territories at the moment. People who are intoxicated should not be sold alcohol. Now that becomes increasingly difficult for the delivery driver the later in the night it becomes. And so you've got to think about the risk you're putting someone in their workplace at delivering alcohol late at night. And that's why the 2-hour safety pause with a 10 p.m. close would mean that the last time alcohol can be delivered is at that 8, like the last time you can make a delivery gives you that 8 p.m.'s kind of cut off, which then reduces the risk. Absolutely.
But you're not going to be able to get a delivery driver doing some risk assessment before he hands.
It's putting them to the later at night they're walking. The later at night they're walking into that premises, the harder it becomes.
And they have safety risks. You know, I think that's very unrealistic. What is realistic though is time. I think that's realistic. I mean, I order wine online, I admit, but that's not for delivered immediately, you know, from wineries.
That's
and
not the
whatever.
fast delivery.
No.
I think that
So
there's a
alcohol
difference.
shouldn't be left unattended either, which currently occurs. It can be left unattended at people's houses. There are lots of things that people need to go and sign for that are lower risk than alcohol being left at someone's premise.
But isn't it more the fast delivery? And we won't mention the company, but I know that there is certainly a company.
Rapid delivery has
the rapid
higher
delivery.
risk, but of course a higher risk category is leaving alcohol unattended as well.
Yeah, I think that the rapid delivery, and that's the sort of the area that I was talking about, I think that the rapid delivery is probably something where, and certainly times and things like that, is certainly something that is realistic.
Yep.
Yes, I'm not sure about some of your other recommendations. I'll hand back to you, Chair.
Good, thank you. Rachel, I just want to say your son Dylan would be very proud of you, and
Thank you.
we really need to hear lived experience, and that's really important to any decisions we're going to make about our recommendations. So thank you so much for that. I'm going to ask you some questions, and I want to drill down into what happened with Dylan, but don't feel that you have to answer any of the questions if you feel they're too personal.
That's fine. Yeah, thank you.
You mentioned that Dylan had some problems at school.
Yeah.
Was that coping academically or peer relationships or?
Yeah, a bit of both. I think he struggled socially, like a little bit on the social fringes. It was a little bit of that, and it was also academically, he had attention deficit, so he...
And was he treated for that medically or?
Treated. Yeah, he was, thank you. He was treated. He was on some kind of medication, but he was on sort of Ritalin or whatever it was for a little while, but then he didn't like the effect it was having on him. He took himself off.
Did the school provide enough support for him?
Definitely not. No, it was because, of our mainstream system, purely and simply. He didn't fit into the mainstream, and Yeah, there were attempts made by the school. I want to say that. There were attempts made by the school to try and, how can we put it, reconfigure or something, the way his, so that his learning, it wasn't like he was learning it differently a little bit, so that he wouldn't have as many subjects or as much subject matter to cover in a day. But it was just more the way that learning was delivered. He just didn't cope so much with sitting in a classroom for extended amounts of time. And then this started the whole situation where a lot of teachers, I guess, just saw him as being a little, not, I wouldn't say difficult, but it starts that, I don't know the word, like...
The struggle.
Yeah, and a struggle between him and teachers became a little bit more obvious. He was being suspended from school, and you know, and I think in the end he just felt like school was just not a place he could. Yeah, it was a very negative experience for him. So that's why he kind of took himself out of that situation. Yeah.
What year did he complete? What was his last year at school?
I think he went to the end of Year 7, beginning of Year 8, something like that.
So was he offered any support after that through the education system?
Not that I remember, no. The school, it sounds terrible, but I think the school were quite happy just to see him gone, to be honest, because they didn't know what to do with him. They did try an alternate schooling situation, which was called Flame Tree, but a lot of children went there that were different to Dylan. They had behavioural problems. Dylan didn't have those behind. He was never violent. He never got, he never hit anybody or got agitated.
And he was drinking by that stage?
No, he wasn't drinking really till around about 16, 17, somewhere around there.
And what was his alcohol of choice?
Well, it really right from the beginning, almost immediately, was the cask wine, because it was cheap.
Yeah.
I would like to see it banned. If I, in an ideal situation, that stuff would come off the shelves.
that directed him because that was the cheapest.
Cheapest, high quantities, high volume wine. It was as simple as that.
Yeah.
He didn't need much money. There wasn't.
Well,
he could go through a whole thing of that, and it was like sugary. It was, palatable, whatever you want to call it. And he got that effect that he was seeking. So the whole thing about drinking from an early onset, was because he had the underlying mental health that started from the school, feeling isolated. I think the word I'm seeking is misunderstood. I think he always felt a little out of touch, a little misunderstood by the teachers and even his peers. And alcohol became a way to feel more included, to feel that there was, he suddenly wasn't as alone, while I was drinking, but it wasn't to last.
More socially interactive.
Yeah, it made him a little bit more socially, interactive, but he still was getting a hard time from a lot of his peers, but which he was aware of.
At that stage, did you try and talk to him about alcohol and?
Always, because my father, history of alcohol.
Yeah.
And then his father, history of alcohol. So I went through 7 years of lots of domestic related violence and all that sort of stuff with his father. But it was more, when I say violence, it was more coercive control, all that sort of stuff.
Yeah.
And then my father, my actual biological father, was violent. So he was a violent alcoholic. So, Dylan's really a third generation. But Dylan was a very passive, placid person. Yeah. So he was he drank to kind of numb himself, completely numb.
Now, one of my frustrations as a paediatrician and now as a politician, I not infrequently get contacted by family, sometimes of patients that I've seen as kids. And I was interested to hear your story of often families feel a bit powerless, so there is this option of having someone scheduled if they're a harm to themselves, and families sometimes find that very difficult to do. But even when they do, it's quite rare for that schedule to be adhered to, and usually gets rescinded. Do you think there's more we could do there if someone's at home?
That needs to change so profoundly. We get a window. I've often talked about this. We get this, sometimes a window, a space to make a difference. And if all those resources don't come together and align at the time, that opportunity's gone. Okay. And I feel like I keep repeating this. So, we had the GP who signed off. He signed off to have him sectioned. Yeah. He got down and Community Mental Health said, under the Mental Health Act, we cannot. He's agreed that he won't harm himself. So he wasn't going to physically cut himself, but he was harming himself through alcohol. But that was not a consideration. Yeah. And then, had he been admitted, he would have got help. He would have been off the alcohol. But the most important thing is his mental health would have been addressed in that facility, which was never getting addressed because it was always his alcohol that was getting addressed. And so he would go home. He was alone. He did live by himself, but I was always not very far. Mm-hmm. So, because there's so many ramifications, there's all the how it impacts on your other children, all that sort of stuff. So he lived by himself. He did quite well, but he just didn't. They're always there's the same problems. They haven't been dealt with. Yeah. So in terms of the mental health, where we would have proper mental health staff, nurses. Yeah. I mean, it would have been laid on thick. He would have been having proper assessments and. Sure. So, but it's really a failure of the system to see that he is actually self-harming. But he is self-harming. Yeah. Yes, definitely. Yeah. He's self-harming, and that's another thing. It's not considered a form of self-harming, but it is. We need to work on that. Were you ever in contact with a drug and alcohol specialist doctor? Well, his psychiatrist was considered to be alcohol specialist, but that's a stretch. Really wasn't, in my mind, it wasn't what I would consider. Now, I just want to take you to something that I know you find very painful, and please forgive me for that, but I just want to hear about when he was in hospital with the hepatic failure, and they refused him transplant. 3 times it was requested by his gastroenterologist. Was that because he said he would not stop using alcohol, or...? No, nothing to do with that. It was all based on his history of drinking. Never once was it considered how many attempts he made. They do score, they have a score or something. I don't know whether that do you know anything about the score?
Yeah, it's a similar process with lung transplants. So
it's a
multidisciplinary meeting. So it's a room full of people, not just doctors, and there's social workers, counsellors, etc. And it's the same process with liver transplant, and they basically come to a consensus. So there would have been a number of factors feeding into that decision.
But were you involved in that process?
I wasn't. No, I wasn't involved. So it would have been medical and psychological.
All of it, even beyond that.
Right. So they would have been looking at past failures as well as
everything.
Yeah. But they never factored in his age. They never
look at supports.
I was just going to say that they didn't factor in that he had an extremely supportive family. Like we would have gone to the end of the earth for Dylan to save him. So there was a lot of things that weren't brought into that consideration. And I regret now that I didn't go over and personally meet that team, and present my side. I can't go back now to that. But I do, and I even looked at being a donor myself, and that was almost laughed at as being insane because it was just not even done in Australia. Apparently it's not even a thing that I've been told.
Has been done in children?
Done in children? They mentioned it has been done in children, but not in someone. I mean, there was the thing that we felt quite misled because we were told there was still a chance that he would survive. That was probably one of the worst things, cruelest things that they could have done to us. So for 2 weeks, we just thought his bilirubin would come down and and at one stage his platelets did decrease, I think. Is that what? Yeah, decreased.
Increase.
They increased a little bit. But it was very minimal. And for the most part, they even threw sort of steroids at him and did all sorts of things. It was very obvious that he wouldn't have survived without a liver. And, you know, I just think that that was the one thing that could have saved him, that they didn't perform. And I'll never understand why they didn't consider him, other than his history. I don't know where they get to make that decision because we have no way of really knowing whether he could have turned things around. I mean, I know that they're looking more and more at this in America, in Johns Hopkins University Hospital, with the effect they're saying that liver recipient who have had a background of liver hepatitis have the same outcomes as people that have liver cancer, and you know there's a very high chance that they will they will actually benefit and go on to live a healthy life. So it's just very slow over here in terms of that change, and
Well, it's certainly tragic. You know, his age is so young.
It's too young to have gone that way. But yeah, like I said, they probably did have. I probably would have benefited from talking to the team at some stage, but they never reached out to find out how they came to that decision. I would even to just get some sort of closure around that, but we never received it. So.
Okay. Now, Katerina, we've heard about the marketing, we've heard about the availability. Talk to me about volumetric pricing and minimal unit pricing.
So I think that Rachel's experience with cask wine being the alcohol that's been used is one that we hear quite frequently. And it's because when it comes to cask wine or any fruit-based alcohol products, they are taxed in an ad valorem way. So the cheaper the product, the lower the tax. When it comes to spirits and beer, they're taxed based upon their volume, which is called a volumetric tax, albeit at different levels. So when it comes to wine, you can produce 40 standard drinks and sell it for between $10 to $15.
We have heard about wine being very cheap.
By far the cheapest because it has this ad valorem tax. And the thing is, then there are a whole bunch of rebates which governments provide to wine producers as well, which means that the vast majority of wine producers pay no tax at all. And so we're in this scenario.
Is that right, to pay no tax?
Yes. So we're in this scenario where, and then we've heard about really large companies reshaping themselves as smaller companies to avoid taxes as well. A whole range of different things that the ATO keeps trying to make improvements around. The other thing that happens is because there is this loophole, you see products that mimic spirits-based products. So you can walk into a store and see a product that might look like vodka, and it gives you that higher level alcohol content, not quite what you would get from a spirit, but it might be instead of the 30 odd standard drinks for a spirit, you get 15, so higher than wine even. And they can sell it for $9 or so because the base that they're using to produce that product is a fruit base. So there are these mimicked spirits products, and ironically, they're often sold in like little IGAs or bottle shops near nightclubs, or because they're the product that's used to kind of top up. So this is a huge loophole that's driving a lot of change. We've done a lot of modelling on changing this across to an ad valorem rate at different levels. To a volumetric rate at different levels. You can categorise wine in different ways, but at the moment, really bulk cheap wine is being favoured by this tax system. And so by moving to a volumetric rate, depending on the rate that you choose, those premium wines, their tax can be adjusted, and the lower price wines tax can be adjusted as well. But it absolutely contributes to this harmful consumption, and it hasn't been addressed. It's something that's hanging there, has been recommended by countless reviews, but hasn't been addressed.
Right. What about minimum unit pricing?
Well, the one place that we have minimum unit price in the country is the Northern Territory. It's at $1.30 a standard drink. The Northern Territory currently has a bill before it to repeal that minimum unit price. The minimum unit price is an effective measure as part of a group of preventive measures to help to reduce harm, and would like to see it across the country in every state and territory. It is something that states and territories are moving on, though, because the federal government isn't moving on looking at shifting that ad valorem wine-based tax to a volumetric rate.
Right.
So we think that that's really important, because the difference with the minimum unit price as well is that the revenue goes back to the retailer, whereas with the taxation, the revenue goes to government to help to pay for the $66 billion of alcohol harms.
Yeah. One last thing. Number of outlets of availability of alcohol. Is there any way that planning laws can be used to reduce the number of outlets?
Absolutely. So at the moment, when a liquor licence is applied for, depending on the type of building application you need, you'll go through a planning process and then you'll go through a liquor process. At both of those points, we've seen decisions made around this. First, the Liquor Act predominantly has to be used, though, to say that density is a consideration. That's the first thing. And also to say that a primary objective of that Act is to prevent and reduce violence, family violence. Mm-hmm. And then the evidence around the connection between those two things need to be considered as well. So Liquor Acts can be strengthened to address the density. We need to, though, rethink the way we look at density because of the digital expansion of alcohol, with every phone being a bottle shop now.
Yes.
Can I ask a question when you're finished?
Yeah,
Just
we
really
will have to hurry. So.
Yeah.
Katerina, the last comment you made on gender-based violence, a lot of our public health messaging has been around men fixing their behaviour, right? And I don't dispute that there's an issue there, but that messaging has not really, I don't think, touched upon the interaction between men and the culture of drinking. I don't see it. What are your thoughts there?
Yeah, there are some really... I have a health behaviour change background. I feel very strongly about really good public health campaigns. And I think that we have this situation with violence prevention campaigns where they're not applying public health principles in the way that they need to be applied. So we need to think about things like who are they trying to move and how are they trying to move them? And if one of the things is to move men based upon the range of behaviours that contribute to violence, then alcohol needs to be a part of that. There are lots of factors that contribute to violence, but, we know that this is a space that our colleagues and friends at Movembers feel very strongly about as well. It's having those strength-based campaigns that are based on a theory of change of how we move people. And they need to be properly funded and invested in. And it's also important to just note that in this country, despite the problem we have with alcohol, we're not aware of ever there being a federally funded campaign for alcohol and harm, with the exception of the binge drinking campaign that happened for a really short time in the early 2000s. And so this is a massive gap in this campaign funding and this awareness raising, and a lot of the harmful drinking and a lot of the harm caused by alcohol happens with men. A lot of the conversations still remain around women and the shifts in women's drinking. So there's a lot to unpack there and a lot that needs to be done.
Good. Well, look, we could question you for a lot longer, but we're running out of time. So thank you for coming today. If you've been asked to provide any additional information, please forward it to the Secretariat by Friday the 14th of February 2025. You'll also be sent a transcript of your evidence and will have an opportunity to request any corrections to transcription errors. I'll just add two things. One of the first events in Parliament House when we came back here was one sponsored by the alcohol industry for the parliamentarians.
They tend to have their beginning of year drinks.
Yes.
Yep.
And
highly problematic.
And secondly, we will be having an election before we can get a final report out. There's still much more for this committee to do, but we are planning, if we can, to recommence the committee and the same inquiry in the next Parliament to complete the inquiry with formal recommendations. We will be providing an interim report, though, with a list of the issues. So, any questions you would like to ask us, ask it now. Anything you'd like to ask, Rachel?
I guess my big one, the one that sort of stands out the most to me right now, is why do you think there is this pushback for labelling? Why are we so? I don't know. We sort of tend to steer away from this. This kind of labelling, putting warning health labels on alcohol. It's one of the things that Dylan brought up quite often.
Yeah.
And I just wonder why the pushback. Why is it just when it's so common in a lot of countries now? I need to know.
Yeah, well, it's a good question, and I don't think anyone here would disagree with you. But there are political issues involved in all of this, and we obviously want to make some recommendations, and hopefully you'll be happy with what we recommend. But then it's up to governments to carry through with their
I don't think it's just political though. I think there are cultural issues as well. I think it's been normalised in our culture for so long that it's just seen as a normal part of our lives.
I understand. I just wanted to see that the public has, and particularly young people, have the option. I'm informed. They're able to be informed.
Yeah. Any questions you'd like to ask?
No, thank you. Thank you so much.
Thank you.
I agree with what you say. There's been a lot of inquiries, a lot of recommendations, but not much action. So we need to change that.
We look forward to working together.
Good. All right.
Thank you so
very
much.
much for coming.
Thank you.
Now, will I call them now straight away?
Yes, I think they're already.
Yeah. Okay, I now call witnesses from the National Organisation for Fetal Alcohol Spectrum Disorder to give evidence today. Sorry about that, but we'll be as quick as we can.
No, that's fine. Well, let's see if we can delay it.
Just got a message from did you want to tell you
It's not till 10:30.
10:30, which is about half an hour. One note, Ms. Birch will need one part of the question, so she has requested not getting multifaceted.
Yep. Yes. Are my colleagues aware of that?
Yes, they are.
Good. Okay. I now welcome you all to give evidence. For the Hansard record, before giving evidence, would you please state your name and the capacity in which you appear before the committee? This hearing is a legal proceeding of the Parliament. The giving of false or misleading evidence is a serious matter and may be regarded as a contempt of the Parliament. The evidence given today will be recorded by Hansard and attracts parliamentary privilege. I will invite you to make a short opening statement, but before we do that, I'll introduce my colleagues.
Hi, Dr. Michelle Anandaraj, a member for Higgins.
Sorry, Jenny Ware, member for Hughes.
Mike Freelander, the member for Macarthur in southwest Sydney, and I'm a paediatrician by training, so I'm very interested in your evidence. And Elizabeth Elliott is a very good friend of mine. Yeah. So, I now invite you to make a short opening statement of no more than 5 minutes before we proceed to discussion. As I have discussed with previous witnesses, if you would like to give some evidence in camera, you are welcome to do so. If you can just let us know if you have any information you prefer to give in camera. I note Ms Birch has asked for us to make our questions one at a time, and happy to do that. So, who would like to start?
I think I'll kick us off if that's okay. Firstly, can I just say how nice it is to meet yourself and sit across the table, because I know about your extensive involvement and history with FASD, so I'm delighted to hear that you were chairing, so thank you. So good morning, my name is Sophie Harrington. I'm the Interim Chief Executive Officer for No FASD Australia. That's the National Organisation for Fetal Alcohol Spectrum Disorders. I will just start my timer, otherwise there's a chance I will speak too long. And not only am I speaking today as the interim CEO, I also am speaking from a point of lived experience of FASD as well. And thank you for this opportunity for allowing us to speak today. For over 25 years, NoFASD has been the national voice for living and lived experience at the forefront of advocacy, education and support for individuals and families impacted by FASD. FASD is often overlooked in broader discussions on alcohol-related harm, and yet the impact of alcohol on a developing fetus has been known for more than 50 years in the English-speaking world. The profound and far-reaching impacts of FASD remain under-recognised with national AOD strategies, leaving significant gaps in prevention, diagnosis and care. These gaps perpetuate health and disability justice inequalities and systemic disadvantage for individuals and their families. FASD is caused by alcohol exposure at the earliest stages of the human life cycle. The impact is a lifelong physical brain-based disability which is often hidden, misdiagnosed or a missed diagnosis. It's important to consider when we talk about prenatal alcohol exposure that the onset of pregnancy symptoms are commonly experienced around 5 to 6 weeks, and that at least 40% of pregnancies are unplanned or unintended in Australia. With this in mind, and when we take into consideration Australia's drinking culture, we can start to create a picture of what the actual prevalence of FASD in Australia could look like. Canada and the US report national prevalence rates of around 4 and 5% respectively. Australia's alcohol consumption rates are higher than these countries. Australia needs a national prevalence study. As the interim CEO of NoFASD, you would likely assume my knowledge of FASD to be reasonable, and with previous management roles working with marginalised populations, I too believed this when I joined NoFASD 7 years ago. I soon learnt, however, that I came with my own unconscious bias. Like the majority of society, I othered FASD. I learnt for the first time 7 years ago of the harms that can be caused by alcohol even before a pregnancy is confirmed. The realisation soon emerged that the processing, planning, working memory, learning, development, sensory and behavioural challenges my blonde-haired, blue-eyed 12-year-old son experienced could in fact be due to his alcohol exposure before my pregnancy confirmation at 6.5 weeks. As a Friday night social drinker, and I use that term in quotes, my son's exposure to alcohol in utero would be deemed as low by the layperson on the street. However, in clinical terms, the 3 to 4 occasions of 6 standard drinks would be defined as moderate risk in pregnancy. A very long story short, my son was diagnosed with FASD in 2021 at the age of 14. With diagnosis came many mixed emotions, guilt and regret amongst them. However, the resounding ones were validation and relief. We now had an answer to help us better understand our complex and beautiful young man. Individuals with FASD have a diffuse brain injury and often function at half the chronological age. They are at much higher risk of experiencing mental ill health, substance misuse disorders, health issues, disengaging from school and becoming just as involved. And yet, we have dinner table conversations about causal factors for the increased rates of incidence across these areas. But how often do we actually talk about alcohol harm in utero being raised as a potential factor? Mainstream education is needed. We must have courageous conversations and address the elephant in the room, which is alcohol. I could spend the next week detailing lived experience stories of the families and adults we support at NoFASD, heart-rending stories of child-to-parent violence, self-harm, high levels of vulnerability due to wanting to fit in, repeated school suspensions, behavioural reports due to their needs not being met in classrooms, the toll of repeatedly having to defend the brain-based behaviours others judge as intentional and as poor parenting, the burden of repeatedly retelling the story to explain behavioural symptoms, accommodations and supports their child needs, even to the very people who are being employed to provide said supports. The overwhelming sense of not being heard, listened to, believed or understood, and the constant advocating what should be basic human rights across all systems individuals engage with. The Australian Government Department of Health and Aged Care should be applauded for their commitment to the implementation of the National FASD Strategic Action Plan. However, FASD prevention and training must be embedded into the National AOD framework, universal screening for alcohol use in pregnancy, sustained public awareness campaigns and culturally safe education programs tailored to at-risk communities are essential. FASD-informed care must be implemented across AOD services. We've heard such an example today talking about AOD services, with treatment models adapted to recognise the approaches required to support individuals with a brain-based disability rather than continuing cycles of ineffective rehabilitation. Through education, policy reform and sustained investment, we can prevent harm before it occurs, but we must remember FASD is not just a health matter, it is a social matter as well. It needs cross-sector collaboration, recognition and support, something that has been championed by our organisation and many others for more than 25 years now, and something that really needs to be actioned soon. Thank you.
Thank you. Ms Bruce or Ms Birch, would you like to make a statement?
I'll go next and I'll make a statement. Thank you. I will talk quite quickly because I just want to get a lot in a very short period of time. My name is Jessica Birch and I live with fetal alcohol spectrum disorder. I received the diagnosis of FASD with the sentinel facial features in 2019 at the age of 33. As an advocate, I use my experience to educate health professionals, government, carers and the broader community to understand what is a common and heavily stigmatised alcohol harm. And I'm here today to speak on behalf of the thousands of unsupported Australians who struggle every day with preventable diffuse brain injury. Time today doesn't actually allow me to fully communicate the difficulty, confusion, humiliation and profound emotional pain of living with undiagnosed FASD, or the many, many years of physical and mental illness during my journey to diagnosis, throughout which I was often blamed for my functioning, denied referrals, gaslit, scoffed at, and regularly dismissed and belittled by the medical professionals from whom I was seeking help. Nor can I fully detail the ongoing challenges I face today in accessing informed healthcare and informed NDIS support. Suffice to say, had my mother not intervened in my healthcare or had I not received the family support that I did, it is arguable that I would be a living, breathing person in front of you today. Such was the deterioration of my physical health and the severity of my despair. Please understand that FASD is a blanket term for a range of complex disorders presenting in myriad combinations due to the individual variations in timing and amount of exposure. This is a full-body physical injury associated with over 400 comorbid conditions and high rates of secondary disability due to stigma, misdiagnosis, and lack of support. To assume my experience based on my appearance and my language is a mistake. My diagnosis includes many cognitive challenges in areas of executive and adaptive function, emotional regulation, academia, working memory and attention, as well as a range of disorders and secondary issues that I need significant and ongoing support to manage. These include attention deficit disorder, rejection-sensitive dysphoria, sensory and auditory processing, interoception, disordered sleep, disordered eating, malnutrition, chronic iron deficiency anemia, dysautonomia, orthostatic intolerance, chronic fatigue, burnout, generalised anxiety disorder, mass depressive disorder, and trauma. And this list is not exhaustive. I also present with many symptoms associated with autism spectrum disorder, such as toe walking, echolalia, stims, compulsive repetitive behaviours, as well as significant difficulties with social participation and peer relationships. These issues have been present since childhood, and the signs of exposure were present post-birth and throughout infancy, illustrated by my low APGAR score, poor sucking reflex, cartilage anomalies in the outer ear, and clinodactyly of the fifth fingers. Late diagnosis and lack of early support has profoundly impacted my educational experience and outcomes, as well as my employment opportunities, housing security, and my connection to community, despite my strengths. And I really deeply grieve my lost potential. It is often said that FASD is the difference between what you know and what you can do with what you know. My strength is my ability to communicate this reality to you when so many others who share my struggle cannot. FASD doesn't just appear, it gets missed, often hidden behind bright, engaged children whose many strengths belie their struggles. Time and time again, these challenges go unrecognised until the consequences are irreversible, and this can no longer stand. Today, FASD is the leading cause of non-genetic disability in Australia, yet it remains the most underdiagnosed and misunderstood. Too often, it is mistaken or purposefully misdiagnosed as autism and ADHD, leading to incorrect treatments, inadequate support, and poor outcomes. This failing denies individuals the opportunity to understand themselves or heal, compounding trauma and leading to secondary disability with devastating consequences, mental illness, addiction, homelessness, incarceration, and suicide. FASD is not autism. Accurate diagnosis is not optional, it is essential. Thousands of individuals such as myself continue to fall through the cracks in healthcare, education, employment and justice, living in the shadows of stigma and systemic neglect. The estimated financial burden of this inequity alone surpasses $16 billion annually. Yet investment in awareness, prevention, early diagnosis and tailored support remains woefully inadequate. Too many lives are defined by struggle rather than potential, not because of their lack of abilities, but because of society's failure to acknowledge their needs. We have the knowledge and the means to change this, and it's time for us to act. I really hope to see my government commit to a national prevalence study on FASD to establish accurate data and drive evidence-based policy. National public health campaigns must be expanded and ongoing to correct the widespread misinformation about alcohol use and pregnancy. Healthcare professionals must be trained and equipped to recognise and diagnose FASD early without the bias and the blame, with routine screenings for prenatal exposure embedded in maternal care. States and territories must apply brain-based approaches and FASD-informed care into education, social service and justice to prevent further harm, minimise punitive responses and unnecessary criminalisation, and provide pathways for individual success.
I might have to get you to stop there because we will run out of time otherwise. But thank you. Ms Bruce, would you like to make any?
Yeah, mine's pretty long too, but I'm going to try and be really quick. My son has... Good morning, my name is Angeline Bruce. I thank you all for the opportunity to be here. I'm a lived experience advocate with experience in alcohol dependency, if you have any questions about that. I won the coin toss, Dylan did not, but I was equally as dependent upon alcohol. My experience covers 4 generations of alcohol harms, including child sexual trauma I experienced from my grandfather, who was under the influence of alcohol, the trauma caused to my non-drinking family, and the lifelong disability my incredible 15-year-old son lives with. That disability is FASD. As the biological mother of a child with an official diagnosis of FASD, I'd like to explain a little bit about what it's like to trying to navigate systems and a society that do not understand my child's disability and frequently stigmatise it. So after a stay in a long rehab facility, I had done many detoxes. I relapsed on the knowledge that after extensive testing, I had 0 chance of falling pregnant without IVF. 0. And something that was especially important to me after the passing of my mother from glioblastoma, an incurable brain cancer that just leaves no survivors. She passed in 2007 after her courageous battle. This crushed me and was a major catalyst into my slide into the hellish existence that is alcohol dependence, although I was set up for that in early childhood from childhood trauma as well. Mum was a rock in an otherwise complicated childhood full of big complex traumas that I was unable to tell her about, and my world completely fell apart after her diagnosis and subsequent passing. She really wanted grandkids, and although she never met my kiddo, I know she'd be super proud of who he is today. I still miss her heaps. When I did fall pregnant against all odds, I was ecstatic and then horrified when I realised just how much alcohol my child had already been exposed to in the first 8 weeks. I disclosed this at my first OB/GYN appointment, and the response I received was not flattering at all. I was told that is not good for the baby, you need to be stopped that, and you need to be stopped that by the time you come back and see me. Again, I was drinking at very large levels. I left that room feeling like an empty failed vessel and without even a referral for help while I was still in relapse and my son not yet viable. I was genuinely shocked, as it had been a vulnerable moment for me to say it in the first place, and it was also enough for me not to disclose again until after my child was born. I could not even tell the midwives why my son was in trouble when he was born, even though I wanted to scream it, sorry. That is the power of stigma in the medical profession and its ability to silence biological mothers about prenatal alcohol exposure. So confirmation of prenatal alcohol exposure is literally half of the diagnosis for FASD. So top clinics can go ahead and do all of the studies and all of the testing, and a big team of allied health team can come back and they can say, definitely we have a clinical diagnosis for FASD, but if I don't confirm that myself, and I believe those conditions are even more challenging in out-of-home care, then there's no diagnosis. So there's many people on the other side, professionals doing all the diagnosis. There's a full 50% that falls on biological mothers to confirm that prenatal alcohol exposure, or it can't happen. So they're people like myself.
Right, it can be very difficult in out-of-home care.
Yes, extremely difficult. Extremely difficult. So my son's first misdiagnosis was autism, also moderate autism, even with his high-risk exposure being disclosed, they were told. I challenged that with a second opinion, and he was formally diagnosed with FASD at 4, so he was really young. He also lives with extremely high anxiety and low confidence. I thought the correct diagnosis would open many doors to appropriate FASD-informed allied health services, and I wouldn't have to disclose again. Sadly, this was not the case, as whilst ASD is broadly known by the public and extensively studied by allied health and medical students across Australia, FASD is not, even though it is the largest spectrum of non-genetic disability in this country. This resulted in his speech clinic and OT clinic also knowing what FASD was, so I had to explain that again. So that's 2 more disclosures for me. And except this time he was there, he was next to me, so he heard this. My little boy heard all this, stuff that I wasn't really proud of. And when he first attended primary school, the same thing happened again. That was another example of my kiddo hearing trained professionals having no idea of what FASD is, even though he knows it's the biggest one in Australia. When he now attends secondary school, but when he went there, there was no appropriate school available to him. Mainstream high school is way too noisy, fast-paced, too many quick transitions. For most with FASD, be it diagnosed, misdiagnosed or undiagnosed. He tested as non-qualifying for specialist school, yet struggles with things like tying shoelaces and running the shower, just to name a few. He now attends a virtual state-run school who I am eternally grateful for, and will be moving to another virtual school for his senior years. But of course he misses out on all the social thing that all the other kids get, because his disability has excluded him from a school appropriate to him. All of those school inquiries and all of the rejections, I rang a few autism schools as well with a bit of a hope. No, was the answer to that, because he had a FASD diagnosis. Really? But that also, yes, but that also meant I had to disclose at least another dozen times to all these different schools, and it's just awful. I really would like if women would only have to say it once, and once it to a GP or someone, or OBGYN, once in when it's time for diagnosis, like at Liz's clinic or one of the dedicated clinics.
I might stop you there and we'll have questions if that's okay. I encourage, as a bio mum, I would just like to encourage you to ask me if there are any burning questions that you think, I really can't say that. They're the questions that I really, really would like to hear as a medical mum. And I'm also a person who did go through 24/7 top-up drinking and somehow made it out the other side. So if there are any questions about that, I'm happy to take those as well, even though this is FASD, so or take them on notice for later. Thank you to all of you for telling us very personal information, and I know that must be very difficult and intimidating, but I just want to read you your information will be very helpful for the committee, and we're very grateful for that. So thank you. Jenny, would you like to start?
Yes, I will look, and I reiterate everything that the Chair just said. Thank you all for your courage, for your assistance here today. I might start with the education challenges. And what if there was one thing that you could have changed when your son started, or was it
health in the room today? So thank you very much.
Great, thank you. My name is Dr. Paul James Clark. I'm presenting on as my role as the Director of the Alcohol and Drug Unit at Princess Alexandra Hospital and Professor of Medicine at the University of Queensland. And So I won't go too much into the background if the committee is happy, because we did have that discussion when you visited. So I thought, and I know you're probably reaching the meniscus of input. So I thought what I might do, if we could introduce it, perhaps, is just 5 thoughts that I could give you about my impression that would be talking points, and we could open for discussion if that would be something that might be suitable.
That'd be great. Thank you.
I think it's key issues. I think I'd present the first issue as the need for meaningful measures of therapeutic interaction in alcohol and drug care. I think to extend on this, I think that the sort of ability to understand how we interact with people with alcohol and drug problems in a meaningful way is different from an interaction. Often community drug and alcohol services and even hospital-based drug and alcohol services would consider a contact or a phone call an occasion of care. I think that it's important to be able to have some metric of contact, but I think we need to be able to distinguish that, or at least the people who fund public health interventions and try to understand benefit need to have a more meaningful way of understanding what an interaction in a healthcare setting is, whether it's psychological services in the community or hospital-based services. So that's really my first point, is that when we're understanding the things that we want to fund as a community, as citizens, as members of parliament, as a health department, I think we need to have a more nuanced and value-based way of understanding what a contact with somebody with alcohol and drug means, and how that might make a therapeutic improvement in their care. My second point, and I'm sure this has been discussed, is around pricing for alcohol. And I know that minimum unit pricing is a really hot and important topic for alcohol services. I recognise that's an important and I think a far-reaching implication for people with alcohol dependence. And I think at a public health level, I think better tailoring of alcohol content to price is critical.
You mean volumetric pricing?
Yes, volumetric pricing. My caution for that is that demand for alcohol in people with alcohol dependence is relatively inelastic. In an economic sense, that means a relative price increase in a price of a good is not necessarily changed the demand for that good. Bread and milk would be an example of an inelastic commodity in our economy. And for people with alcohol dependence, alcohol is a relatively inelastic demand. You can increase price of alcohol, but you do not necessarily change the demand for alcohol in somebody with alcohol dependence.
Yeah.
So the impact of changing a price, volumetric pricing, does not necessarily have the same effect on part of the community that is not alcohol dependent. So unit pricing has a lot of benefits in moderating, I think, alcohol intake in people with harmful binge pattern drinking, younger people who have more constraints on their expenditure, people who aren't alcohol dependent and who might use price to moderate consumption in a more interactive way. But it may not have the same effect on people who are severely alcohol dependent. And that has two implications, is that in people who we know are probably overrepresented among poorer people in the community, that may end up a greater portion of their income being spent on alcohol rather than a reduction in their alcohol intake. And I think that's a really important implication because it may have negative implications. The other thing is that I think, it sounds a bit unlikely, but I think that our experience in cigarettes and tobacco, where we've now got an industry of people who import illegal cigarettes from Russia and China and illegally produced tobacco, means that you really couldn't entertain, we must entertain a situation where illicit alcohol would be produced and be available. We certainly have the technology for that, and that has actually significant health implications if people have methanol poisoning. and may not have the desired effect from a price increase for people who are alcohol dependent who source alcohol in other ways. And we know people with alcohol, drug and nicotine dependence do that. They move around regulation constraints. So I think we need to be thinking like a chessboard about what that effect has, but not just what it has on the Australian community, but people who are affected with dependence. Making S8 opioid drugs less available, prescription only, moving codeine away, making it harder for patients to get endone was definitely a good public health policy. But what it's done is switch a lot of people into other drugs that are sedative drugs like baclofen and Lyrica and other pregabalin and gabapentin, other drugs that aren't constrained by the same S8 constraints.
Yeah.
And so that's that implication of one well-meaning drug-targeted implication,
Sure.
but we have to sort of think about how somebody whose demand for a sedative drug, tobacco, or in this case we're discussing alcohol, how they might manoeuvre to respond to that.
Good.
I think the third point I'd like to make would be around reframing public health messaging around alcohol dependence. I did allude to this in our discussion, and I want to just reiterate it in case it sort of flew out in that bit of a rush chat that we had. The stop smoking public health campaigns have been really, I think, instrumental, and I think we have a lot to learn about alcohol public health messaging from the way we've been messaging about stopping cigarette smoking. When we started talking about stopping smoking, the focus was on the harms of smoking. You remember the TV adverts of somebody taking a puff and swallowing the cigarette smoking and eating up the lung. That was very kind of scary. It's a bit like the early AIDS sort of 10-pin bowling thing. Very, very effective to create fear. Again, with alcohol dependence and people who are drinking too much, because alcohol is very sort of socially condoned and people with alcohol dependence are already slightly removed from healthcare, I think the cigarette anti-smoking education has actually moved towards trying to promote not smoking. That's a really important and subtle difference. So a move from trying to educate people about the harms of smoking and warning them about what they're doing to an unborn baby and warning about what they're doing to their lungs to, hey, this might be you jogging down the street. If you don't smoke, you might be able to chase your kids around the park. Those sort of public messages are actually very attractive, and they create a positive health image around not drinking rather than reinforcing a negative health image around drinking for people with alcohol dependence who already are quite locked in to negative images about themselves. Yeah. And so those sort of negative images don't help to break people out of sort of patterns of behaviour that they're already locked into. But creating positive health images at a public health level do help people sort of think about what they might like to be rather than confirming what they're worried about already.
Yep.
The fourth point I'd like to make would be a sort of broader recognition about chronic liver disease and specifically alcohol-related liver disease. It's sort of almost contrary to what I was talking about with public health messaging, but really trying to understand this as a sort of public health research issue and trying to prioritise MRFF and other opportunistic grants around sort of weaponising our ability to better understand and intervene in alcohol-related liver disease, which is the most common medical problem and occupies the biggest burden of disease and cost from alcohol in our community. So that's the sort of key medical problem, I think, related to our key drug problem of alcohol. And I think we need to re-emphasise alcohol-related liver disease and research into that, and that should be prioritised through MRFF, NHMRC and other vehicles, and I think the committee could have a part to play in that as well. Finally, my fifth point, I'd like to emphasise that I think in terms of a response at a sort of strategic level, we really need to emphasise what I'd call a whole-of-life approach in terms of how we interact with people with alcohol problems. That focuses both on education, prevention and intervention, but it has different weighting of each of those factors at different points in the life cycle, emphasising prevention and education in younger people. But we know that as time goes on and alcohol dependence develops, it's really the sequelae of alcohol dependence, chronic liver disease, neurological disease. And for those people, it's really emphasising intervention and trying to link people into intervention, so that's really the burden of disease. Prevention, of course, at a public health economics level is much better payoff, but at the same time, we pay a bill every year for the cost of our healthcare, and it's actually people who are older with chronic sequelae of alcohol dependence where most of that health dollar is spent. And really that comes back to a recognition of a different health or cost utility at different points of a life scale, and then adjusting your investment and how you invest at each stage of that scale, recognising education and prevention early for younger drinkers and harmful drinkers, and interventions to try and improve abstinence and reduce harm and manage the complications like advanced liver disease. That's really the points I'd like to make to the committee. Thanks for your time.
Great. Well, that's 5 very important points. We'll open it up for questions. Who would like to go first?
I'm happy to go. Thank you, Paul, for your testimony. And we've had the privilege of touring your excellent inpatient facility. I don't really want to talk about the public health measures. We've kind of covered that with the previous speakers, but I do want to delve into your type of care model. You've had, obviously, success in dealing with patients with very severe alcohol use disorder and people on the brink of decompensated liver disease, if not with decompensated liver disease. You've turned them around, and we met one of those gentlemen. Your model is unusual. There are many hospitals around Australia that do not have this kind of inpatient model of care, which for these very severe patients. And we're about to renegotiate, if we're re-elected, the next 5-year hospital agreement with the states as a kind of a catch-all. All the states will be included in that. Can you give us some advice on what you think that kind of model should look like if we were to try and persuade the hospitals to take something like this up?
Yeah, thanks for your question, Michelle. I think providing an integrated alcohol and drug service is a key element to it. So a lot of health services will, again, it comes back to that first point about you really want to get beyond the idea of ticking a box for somebody with an alcohol or drug problem. You want to get beyond that into something that's going to involve a meaningful interaction. And some of the sort of services that I've seen that provide a service but don't provide a meaningful service are really about saying, we've done this, we've ticked the box and moved on. So I think an integrated service provides more layers of control for that. You don't have a roving nurse service, for instance, that has a sort of cut and paste thing, and that's it. It links into a medical service staffed with specialists in addiction medicine. I think it's really important. This is a medical problem, and it needs people who really appreciate the nuances of the disease. So obviously I'm probably biased with the medical model, but I do think as doctors, it's really important that we have our service is medically led and it's medically driven at that level, because we think it makes a difference, not because it's cheaper, because we think it makes a difference. Nurses are a critical part of our service, and really without them, we don't provide the breadth of service that we can provide. We don't provide the intensity of service without medical people, and we don't provide the sort of longitudinal care without psychologists. So in that sense, and a social worker in our unit. And we've had a social worker, psychologists and medical doctors as well as nurses in our unit since it was formed 30 years ago. And that's been really key to it, offering all those factors, because there's multiple issues that fall off when you're dealing with someone with alcohol dependence. So I think a sort of minimum quality criteria for funding a hospital-based alcohol and drug program means that you should have adequately trained physicians, supported by specialist nurses who have expertise in the area, and an outpatient program that involves social work, because that attends to the problems of alcohol that aren't just medical and psychological but are social, and a psychological intervention service that allows patients to have evidence-based care. We know that the two things for alcohol, for instance, that pharmacotherapy helps, but in the PBS, it's only indicated, only subsidised in the conjunction with a cognitive behaviour therapy program. Yet very few hospitals offer a cognitive behaviour therapy program. So one question you might ask is, well, how can we offer evidence-based therapy if none of the hospitals that are trying to intervene with this more severe group of people can't offer the only evidence that we have to make a difference in their life? And that's certainly the big emphasis here, is a structured 12-week outpatient program for patients that dovetails into their admission, so that we try and engage them intensively when they're an inpatient, and then try and continue that in a meaningful way when they're discharged.
And one last question, and you may not be able to answer this, perhaps take it on notice. If you were to estimate how much your service costs a year, do you have a sense of what that cost is?
We're about for an equivalent of, let me just tell you our full FTE to sort of put it in context. So we've got a secretary, one 1.84 social worker. We have 3.5 full-time equivalent clinical psychologists. They're all clinical psychologists, not just psychologists, but clinical psychologists. 2 full-time nursing equivalents. And I run this, I'm also a gastroenterologist. I run this part-time in addition to being a liver specialist with another colleague who's an addiction medicine. So we have a 0.5 FTE medical person. So that's our FTE component, and our budget's about 1.25 million.
That's pretty good. And just one last question. We've also met nurse practitioners who are skilled up in addiction medicine. There's one at the Alfred where I used to work, and she's fantastic. There wouldn't be anything stopping a centre like this, an inpatient centre with this much multidisciplinary care, then also training up nurse practitioners if they wanted to go through that kind of program, right, in order to build capability.
Yeah, absolutely. I don't think it's not so much that it's about integrating that nurse practitioner so that there's, somebody who understands the problems of cirrhosis and the medical implications of the diagnosis, and psychologists who can offer. I mean, I don't purport to be able to provide a 12-week cognitive behaviour therapy program, so we need that. But nurse practitioners definitely have a big role to play, particularly in areas and more regional hospitals where you can't source an addiction medicine physician. I think we have a senior CNC level nurse with 30 years of experience who, had she been coming through the system 20 years later, would be a nurse practitioner for sure.
Yeah.
It's not always the prescription of drugs in terms of a nurse practitioner, I have a nurse practitioner I work with in another hospital in liver. And in that, there's very algorithmic problems like chronic hepatitis B and chronic hepatitis C. The differences here are understanding the medical problems, which I actually do think you sort of need a broader sense of medical sequelae of addiction, and then a broader sense of the social problems. So we have a social worker, and then that sense of longitudinal care through a psychologist. So that's really where it does need to be a kind of one-stop, multidisciplinary integrated care. I don't think having a nurse practitioner solo in a health system would be able to achieve what you really want to, which is that you might be able to see everybody, but getting back to that first point about what is a meaningful interaction with a patient that allows them to change their behaviour and recover. That's really what we're after.
Yeah, okay. And my absolute last question. So just to clarify, the 12-week program you talked about is CBT. And then the other testimony we've heard from community advocates, groups like Windana here in Victoria, in my home state, was one part of the therapeutic journey was actually in reintegrating people's social back into society, reforging more functional social connections, and that was part of the challenge of their therapy. Is that something that you've also had to encounter, or do these patients finish their 12 weeks and then off they go?
Yeah, that's a good question, Michelle. And actually, it's a kind of, it comes back to the nuance of where people are in the sort of process of problems from alcohol. So I don't know in Dunn, but I presume it's a residential rehabilitation program, is it? Yeah.
Yep, community-based.
One of the big things that we do is have an outpatient program. So that we might engage them as inpatients, but we want them to go home. We want them to drive past 10,000 BWS liquor outlets on the way home and sit in the chair that they've always sat in and open the fridge where the drinks have been. We want them to be in the environment that stimulates anxiety or whatever in order to try and overcome that and manage that. So it's very much an important part of our program that we wouldn't do a 12-week program for somebody who happens to be in hospital for 3 months. We might start it, but it's actually the patients at home. And so we don't have to reintegrate patients into their society because they're in the society that they live in. People might be in kind of altered circumstances. So I saw a fellow on Monday, for instance, who his wife won't have him back home until he's been able to make kind of a certain checklist of things to protect their daughters against him sort of harming himself from drinking. So he's not at home, and he's not in a community rehab centre. But we've been seeing him on a regular basis in our 12-week program, and I've seen him sort of 4 or 5 times in 6 months. But he's back working full time, and his wife's sort of ready to have him back in the next few months. And he hasn't drunk for 6 months since he was in hospital and nearly died from a sort of from aspiration. But that only happened because he was in the community and having to deal with the sort of, holy cow, am I going to stop and get a drink? I can do what I like, because the rehab centres, I think they're very important for people for whom the wheels have fallen off completely and they're unable, and they need to just have a prolonged period of abstinence where they can sort of recalibrate everything. But that's probably not the majority of people. It's perhaps more of the patients that we see here in hospital. But the majority of people are trying to live a life, hold a job down, pay a mortgage or rent, and actually manage their problems. And so our focus, and I think it's a big part of the success of our program, is that we have people in the program who are living in their own homes, but they're committed to an abstinence goal. And I really want, another reason why we're more successful, I think, than a lot of programs, because we ask the patients to commit to an abstinence program. And again, last week I had somebody who was a really successful guy who wanted to come and he wasn't sure about it. And I said no, but when he eventually comes, he'll be ready for it. Yeah. So abstinence-focused programs that actually have the patients in their own home, that are outpatient programs that allow them to be integrated. We're not sort of keeping them in an abstract universe and then popping them back in. For those programs, I definitely think a reintegration approach is important. To that end, our social work is really important, because even if you're sort of semi-detached, if you'd say, from society, you've lost your job, you're homeless, or you can't afford rent, that's why we have a social worker here, sort of filling that gap of what a residential rehab reintegration program might do. Well, we want to try and keep them integrated, keep them on some sort of social support. If they can't keep the job, then help them try and find a job. And that's where our social worker comes in, linking them into sort of services and things that might be able to survey that, finding emergency housing and that sort of stuff, or housing commission sort of houses.
Thank you very much, Paul.
Good. Move on to you, Jenny.
Just one question. Thank you very much, Professor Clark, for your testimony today. You've mentioned the role that nurse practitioners could play, can and should play in the whole multidisciplinary care. Do you see a role for pharmacist practitioners as well in the multidisciplinary care, bearing in mind that a lot of the times in regional areas, as with nurses, often when there aren't the medical specialists and things, often there are pharmacists that can play a bigger role in providing patient care.
I suppose so. For back to the sort of pharmacotherapy of alcohol dependence specifically, certainly if we're talking about other drugs, I get nicotine and replacement and that sort of thing, for sure, that would be a really fairly well, I think for that to work well for non-medical prescribing, whether it be a nurse practitioner for that matter, or even a GP, as you move down the pathway, your algorithm for what might go wrong and what other complex things need to be addressed needs to get simpler and simpler. And I think for pharmacists, nicotine prescribing is really quite good. Even the basic pharmacotherapy we have for alcohol dependence, is actually only subsidised on the PBS in conjunction with a chronic cognitive behaviour therapy program. That's what it says on the byline of the PBS. So even I shouldn't prescribe it as a specialist addiction medicine physician unless they're integrated into a cognitive behaviour therapy program. So I guess in answer for that, which would be the biggest problem, I think, was under prescription of medication for alcohol dependence. It's a big problem, but I don't think pharmacists are going to be able to solve that problem, because we need that kind of village approach that I was talking about in Michelle's question, to be able to do that. And having an isolated person in a pharmacist prescribing for alcohol dependence, I don't think would be successful. And the other thing is, there's only 2 real drugs that we have, and one of them is naltrexone, and that's contraindicated in alcohol-related liver disease, which is, again, requires a sort of degree of medical sort of, you don't have to be, I think, an addiction medicine physician for it, but you need to be aware of it. And I think that might be a bit of a problem for pharmacists, I think, in terms of prescribing that.
Okay, thank you. That's it, Chair.
Oh, good. Yeah, thanks once again for your evidence. I'm interested in, and you've been doing this for quite a while now, whether you think the scale of the problem is increasing and whether the demographic of the patients you're seeing is changing. We've heard a lot about younger people drinking more in binges and etc. Where you think we are in that space?
Yeah, well, certainly from a kind of, if I was to use my liver hat for a little while here, we're certainly seeing more people, or a greater proportion of the inpatients who are occupying bed days for alcohol-related liver disease. So 15 years ago, it would have all been Hep C, maybe 75% Hep C. The ability to treat Hep C has changed that radically now, so we don't have the sort of the problems. Probably now, from a liver disease perspective, would have maybe 75% of patients that are in the ward at the moment would be from alcohol-related liver disease, and probably 25% from predominantly metabolic fatty liver disease. So I definitely think from a liver perspective, that proportion of advanced liver disease that's from alcohol has increased for sure. And they often do worse, so they're more morbid. They stay longer, so they occupy more bed days, and their outcomes are poorer, so they die earlier after a diagnosis. And all those things are sort of well represented in the data. Some epidemiological data that's actually under review at the MJA at the moment, looking at changed etiologies in liver disease. I'm a co-author on, actually just reaffirms what I just said, on a 15-year data longitudinal study. So yes, there's more alcohol-related liver disease, and yes, they do worse, and yes, they occupy more of our medical care and medical dollar. In terms of the kind of changes in the distribution, I do think there's an increase in younger women presenting with advanced liver disease early, and also alcohol-related hepatitis. Again, there is some anecdotal data from Australia for that, and that's actually, there's published data on that in the US as well for alcohol-related hepatitis. And that's something that's definitely been observed in the last 5 years, particularly post-COVID.
Yeah.
Alcohol-related hepatitis is a very kind of morbid presentation too, so it's important. So increased representation of women in alcoholic hepatitis, and alcoholic hepatitis in that subgroup is a very morbid presentation. The second change, I would say, has been in an hospital kind of environment, from getting away from alcohol for a second, is injection-related infections from methamphetamine. That's really sort of just keeps on growing, I think, and occupies quite a lot of bed days. And these are really difficult people to treat in a sort of meaningful way, going back to what we do.
Yeah.
And very morbid spinal infections from injection, endocarditis, valve replacements, recurrent infections, recurrent disability, spinal disability, quadriplegia, and that sort of thing. We see that really frequently. And so that's a big problem, and I think that continues to mount up. We used to have about 60 to 70% of our burden in hospital here, in a quaternary hospital, is about alcohol. But the shift has been within sort of stimulants and benzos and cannabis and opioids. Now we don't see a lot of heroin-related injections and people coming in with opioid problems, except polypharmacy maybe. It's much more stimulants and methamphetamine. They're probably more like 25% of our inpatient reviews compared to about 15% longitudinally.
Yeah. And I'm assuming they also come with other behavioural issues as well and aggressive behaviours.
Yeah, often really difficult to look after. You can imagine if you've got a sort of bacteremia or deep-seated infection, you're going to need 4 to 6 weeks of antibiotics through a PICC line, which is just such a hard thing to try to organise for somebody who injects drugs. It's really challenging, And so they have to stay in hospital where their PICC can be locked up, put under a lock on the, and still they will inject around that and disappear. Or even worse, they'll discharge against medical advice and they'll come back in again. So, and that's probably a problem of the therapeutics. We don't have great therapeutics for stimulants and methamphetamine in particular.
Mm-hmm. Yeah, good. I just want to go back a little bit. I am interested in the public health messaging. It just seems to me that we've got this battle, if you like, with the alcohol companies, whose marketing is unbelievably sophisticated and using, online tools and algorithms and things to target people. And it just seems to me we're failing with our messaging to people.
Yeah, I think that's really on the mark. I think it's a good example is zero alcohol. Zero alcohol. I don't think we exactly know the implications of zero alcohol. It's probably not. It's not going to be the cure-all. I think it's going to be good for younger people where we're trying to not develop problems and they're trying to think more broadly about using alcohol and stuff. Maybe not great for alcohol-dependent patients. But the way that's what we think of. That's how we think of it. Oh gosh, it's got to be a good thing. The alcohol companies are considering this as a way of placing their brand in a non-alcoholic way, so it can transition somebody as they learn to drink into their brand.
Yeah,
that's how they're thinking about it. So the Heineken Zero becomes a Heineken Light, becomes a Heineken Heavy or whatever you like. The brand doesn't really matter. And the other thing, which is what happens in the sort of craft beer market, is that the big, huge liquor companies see an opportunity, take it over, and then they're not really interested in developing that market. It's a bit like, petroleum companies occupying renewables. It's not their core business, but they want to control the competition. The other thing I think that sort of limits that messaging is that the funding from a lot of those public, the biggest one we know of is the Drink Safe program. Have a think about that in terms of the messaging. Drink safe. What's that saying? It's not saying don't drink. It's not saying try no. It's actually saying keep drinking, but try and do it safely. The most strongest message we could have about the harms of alcohol was keep on drinking, but try and do it safely, as opposed to reframing that don't drink. And that's really, and so everything's got to get over this barrier of the self-interest of alcohol companies. And we don't really, I think, we don't generate all the potential harm, particularly from a gambling perspective as well, the ancillary problems that the alcohol has, where we might be able to bring funding from the gambling industry back in to address alcohol. I think we could do better at that as well, to try to come up with a bit of a fighting fund for public health messaging that's funded by some of the rewards that's related to alcohol from gambling and that sort of thing as well. But I definitely think they're so far ahead of us in terms of their messaging. Yeah,
very sophisticated. We're going to have to leave it there, I'm afraid, unless there are any further questions. Thank you once again for the site visit, also for your evidence today. We are going to head towards an election pretty soon. We are intending to put out an interim report of the issues, but not with recommendations. And we are planning to re-uptake this inquiry in the new Parliament. Hopefully all the committee members will be here.
Good luck.
Yeah.
Next week.
But is there anything you'd like to ask us about the inquiry?
No, I just, thanks for, I think, if nothing else, the inquiry starts to, promote this problem. I think we do need we need to think about this strategically and structurally. It needs to be an inquiry. We need to be doing things about this that kind of promote it as a health problem. And I think it is undermined by the, general sort of society's alcohol's really imbued with social mores and, as we said, the other interests in society that want us to be drinking more. So we actually need people from the public and from government to be starting to sort of fight back on that. So I think it's great that the inquiry's started, and thank you for your efforts.
Great. Well, thank you very much. Thanks for coming today. If you've been asked to provide any additional information, I don't think you have, but please forward it to the Secretariat by Friday the 14th of February 2025. You'll be sent a transcript of your evidence. We'll have an opportunity to request corrections to any transcription errors. And once again, thank you very much.
Thank you very much, Chair, and thanks to the committee members.
Thank you.
Thanks.
Good. I now call the Department of Health and Aged Care to give evidence. Thank you for coming today. We're waiting for one of your members online, I think.
I think Robin is online.
Right.
Yeah, Professor Langham is online.
Good.
Unfortunately, I do not have a name tag.
So we have.
Can we make
We
one up?
might need an extra name.
Thank you.
Bring up a blank name card.
Thank you. We have two colleagues outside. Are they coming in? We have two colleagues outside. Have they been notified?
So thanks for coming today.
Thank you for inviting us.
Pleasure. We'll start shortly, hopefully. I'm Mike Freelander. I'm member for Macarthur.
Michelle and Roger, member for Higgins.
Jenny Wayman.
No more lost witnesses.
There are some witnesses who should be coming through now.
So I'm just waiting on your name tag.
That's all right. Do you want me to?
Okay, so we.
Thank you very much.
All right, well, I will now welcome the witnesses from the Department of Health to give evidence today. For the Hansard record, for speaking, could you please state your name and the capacity in which you appear before the committee? This hearing is a legal proceeding of the Parliament. The giving of false or misleading evidence is a serious matter, may be regarded as contempt of the Parliament. The evidence given today will be recorded by Hansard and attracts parliamentary privilege. Before inviting you to give a short opening statement, we have offered other witnesses the ability to give evidence in camera if there's anything that you think should be kept confidential. But otherwise, I now invite you to make a short opening statement. Thanks very much for giving your time to us today.
Thank you very much, Chair. My name is Trish Clancy and I'm the First Assistant Secretary in the Population Health Division of the Department of Health and Aged Care. So the Department thanks the Committee for the opportunity to appear before the inquiry into the health impacts of alcohol and other drug use in Australia and to provide an opening statement. I first wish to acknowledge the Ngunnawal people as the traditional custodians of the land on which we're meeting today and to recognise any other people or families with connections to the land of the ACT in the region. I want to acknowledge and respect their continuing culture and the contribution they make to the life of the city and the region. I'd also like to acknowledge other First Nation people who may be here today or listening. The Department has reviewed the submissions to the inquiry and followed the hearings throughout. As the inquiry has heard, alcohol and other drug harm minimisation is complex. Harm minimisation requires a coordinated and collaborative effort from across governments and also the non-government sector. The Department is focused on accelerating efforts to reduce the harm associated with alcohol and other drug use. We acknowledge the invaluable insights that those with lived experience have in guiding policy thinking and investment opportunities. The Department's work here is aligned with the National Drug Strategy, which outlines a shared commitment to harm minimisation between health and law enforcement agencies at the national and jurisdictional level. Since July 21, the Department has administered over $880 million to support prevention programs, treatment services, and harm minimisation between health and law enforcement agencies at the national and jurisdictional level. Support prevention programs, treatment services, research and data, and communications activities under the alcohol and drug program. We also coordinate evidence-based responses by working collaboratively with other government agencies, state and territory governments, service providers, advisory bodies, peak bodies, research institutes, and the broader community. We remain committed to working closely with all levels of government, as well as the broader sector, including those with lived and living experience, civil society and affected communities, to develop, implement and monitor evidence-based approaches to reduce alcohol and drug-related harms. We thank you for your time and we look forward to your questions.
Thanks very much. Anyone else like to make a statement? No. Professor Langham, you don't want to make a statement at all? No. All right, we might proceed to questions. Any questions? Michelle?
Yeah, thank you. This is obviously a huge topic. I guess, my impression so far with this inquiry is that we have a highly fragmented system. That's fragmentation itself is causing harm to patients and their families. It is a challenge for them to navigate, and there doesn't, I really would like us to be able to, one, improve that, join up the dots between community, primary health and hospitals. And I'm just focused on treatment here. I'm not going to talk about public health for the minute. At the moment, it's so hard for families and patients to find the care they need when they need it. It is so fragmented. I do like the idea of trying to establish a no wrong door type mechanism. Waiting lists are long, but I have seen also examples or exemplars, really. We've just spoken to Professor Clark, he's an exemplar. There are regional centres I've been to which are exemplars. So there are these kind of islands of best practice, but they're just not joined up in any coherent system. So you did talk about coordinated and collaborative effort is needed. What can the department do in taking a kind of a leadership role in joining all of this up? Or what kind of levers do we need to apply to help join all this up?
I'm happy to take that question. Ben Medalia, Assistant Secretary, Alcohol and Other Drugs Branch in the Population Health Division of the Department of Health and Aged Care. And I think your points are well made in terms of the complexity that exists within the system. So, and that's just in relation to alcohol and other drugs. When you look at the range of issues that underpin use for people, particularly with problem use, that even complicates the picture even further, because we can see people whose need for other services are also part of that spectrum of need that needs to be addressed, whether it's things relating to housing, homelessness, other social and emotional wellbeing activities. And the fact that we have arrangements at the moment where responsibilities are distributed both across multiple sectors but also across jurisdictions makes not only the issue of governance and coordination of effort and policy direction somewhat tricky, noting that we do have overarching documents like the National Drug Strategy, which at least provide guidance around how we're all playing in this space. But at a really practical level, I think anything that has those multi-jurisdictional, multi-sectoral arrangements becomes a trickier thing to navigate and also coordinate at a practical level, whether you're implementing at one end and designing, or whether you're a consumer trying to work your way through that system. I think we're at a point where we're coming to the end of the National Drug Strategy's life. Obviously, a decision of whether it continues is a question for government, a matter for government. But I do think that presents us with an opportunity to look at what refreshed both policy design would look like, but taking into consideration these sorts of issues and these sorts of challenges, and how do we ensure that we are engaging not just with our jurisdictional colleagues in this space in a way that ensures that we're seeking to address those issues, but how do we make sure that there are other voices as well that inform what that needs to look like, particularly from a consumer's perspective and a service provider's perspective. So I think, consistent with what Ms Clancy was saying in terms of really looking to be more collaborative, there is, I think, a structural opportunity for us to do that at a very high policy level, let's say, a strategic policy level. But that doesn't discount that between now and then we have a whole range of arrangements where we can activate conversations with jurisdictions, we can activate conversations with peaks and service providers that already occupy this space and that we have relationships with. The ability to bring all of that together, though, is a logistical task in and of itself, but we are looking at ways in which we can bring that more tightly together, I think, and in a more strategically informed way.
Yeah. That's good that you're thinking about that as well. So I think first is, how do we find best practice and scale it up? It seems ad hoc at the moment. The second is, how do we embed lived experience into this process? And I think you touched upon that in the next strategy. The other question I have is, I'm not going to get the name right because I can't remember it, but I gather there was some sort of ministerial advisory kind of body around alcohol use that was disbanded, I think, in the early years of the pandemic. And so that kind of federal-state connection was lost. What are your thoughts about reinstating a body like that at a ministerial, First Minister's level as well?
So I think probably the first thing to state was that it was a decision of government, and so the re-establishment.
What was it called? Sorry,
it was called the Ministerial Drug and Alcohol Forum.
Thank you.
And so whatever governance might be established that would address the sorts of, let's say, the way in which you might structurally approach some of these issues would again have to be a decision for government. That's not to say, though, that we don't have ministerial arrangements in place currently that enable us to address some of these issues. So Health Ministers meeting, for them to invite ministerial colleagues from other sectors. I suppose the issue is that they have a broad spectrum of issues that they need to attend to. So we have seen health ministers deal with things like opioid dependence issues and the kinds of policy reform that was needed in that space. But I take your point, which is, how do we have something that's potentially more focused?
So to sort of look at that, what has been lost since the abolition of this forum, because when you look at burden of disease, alcohol particularly, and then drugs are collectively a huge contributor to burden of disease along with tobacco, right? I mean, they're always up huge. I mean, that to me would suggest that this sort of leadership body would actually be a useful thing to have. With its abolition, and I'm assuming you've been in this role for a lot longer. You've seen this over time. What do you think has been lost with the abolition of this body?
Neither of us have been in the role very long.
Oh, really?
That's right.
Oh, what a shame.
So we don't have a pre and post history to reference.
Beg your pardon, right. What a shame.
We do, though, work with our peers at a level of the administration, and that has not stopped because ministers don't have a special forum. And so that continues, and it continues on a regular basis.
And is alcohol and drug, my last question, at that very high level, the ministerial level, is this a standing item that is discussed at every meeting, or again, is it ad hoc?
No, my understanding is ad hoc as issues arise.
Okay. Thank you.
Look, I'm just interested in whether you have any data about whether this alcohol war is getting worse or getting better, and do you keep details of things like deaths from alcoholic liver disease, hospital admissions, whether we actually have measurable statistics about the problem.
So Ben will take this one.
The luck of the draw. Yeah. We do have data, and it's collected through a range of different mechanisms.
Yeah.
I think it's important to probably disaggregate the scale and the intensity of the issues in terms of trends as well, depending on cohort.
Yep.
So you heard from Professor Clark just
Yes.
previously that young women in particular are a cohort of significant concern, I think, given that their trend is different from young males as well. So we see young males falling in usage, certainly we see among younger people, and I'm talking about people around the age of mid-teens and that particular age bracket. Mm-hmm. That's falling.
And you have those details?
We have those statistics, and we can break that down, and I think our submission includes the trends by sex and by age cohort in terms of whether use is increasing or decreasing. But we also have data, to go back to the other dimension of your question, around the range of related health conditions that are associated with alcohol consumption that are of concern as well. So we know that alcohol use has contributed to 3.6% of the total burden of all cancers and other neoplasms, for instance. That's AUHW burden of disease data that's collected. In terms of interactive data on risk factor burden, so alcohol was more likely to contribute to certain cancers. 29.8% of nasopharyngeal cancer total burden in persons was attributed to alcohol use. 27.8% of lip and oral cavity cancer attributable to alcohol use. 24.3% of liver cancer was attributable.
Do you think we need to get that data out to the public as part of our public health response?
I mean, I think anything that improves consumers' and citizens' health literacy can only be a good thing. I suppose the question is, how do you do that in a way where the messages stick and compel?
And has the department looked at that?
So we are, I think there have been numerous communications campaigns over the years. I wouldn't be able to speak in detail to what the messaging was, but we have an opportunity for continuing campaigns.
Just doesn't seem to be much at the moment, and we are being faced with a deluge of marketing by alcohol companies on all forms of media.
So we do have quite a bit at the moment in the pregnancy space.
Yep. So,
making sure that parents-to-be know the risks of alcohol at this time and why one drink is one drink too many, essentially. So that one is quite
we
active.
just heard from the Fetal alcohol group, They seem to think that the message isn't getting out. So is the department looking at trying to
we're continuously looking at what we can do to improve in these areas.
Yeah.
As we go, as we see the statistics, looking at what research can be done, we fund kind of 5 research centres in this space to help us address the changing nature of use.
Okay.
And probably to pick up on Ms Clancy's point as well, I mean, and I don't want to disagree with previous witnesses, but we do fund the Every Moment Matters campaign, and so there's some pretty compelling statistical data in there that says things are improving, at least in terms of survey respondents, around a range of different measures which we could provide to the committee.
That would be good. Yeah.
Rather than going through every statistic now.
Yeah. Now, is it right in saying we've heard some evidence that the alcohol companies interact with the department about their marketing, or not?
Give me one moment, I can tell you some of the ways, or one of the ways in particular that occurs. I mean, so from as a matter of standard practice, the department engages with as many stakeholders as it can. There's probably only one specific mechanism through which we have a structured way of engaging with representatives of the alcohol industry, and that's through the Australian Beverages Advertising Code scheme.
Yeah.
So there's a management committee that is responsible for managing and reviewing the operations of the ABAC scheme, and that committee includes a representative from the department, which is myself, and then other representatives from the alcohol industry. And it really looks at the packaging and marketing of alcohol and to see whether it's compliant with the code. And so there's a separate independent
compliant with the present
panel.
code.
That's right.
Do you make suggestions about what should be done or not?
So there was a proposal recently to amend the free TV code around advertising, and the department did put forward I don't know whether it was a submission stating that the proposed amendments we thought would increase the risk of younger people being exposed to alcohol advertising, which we thought would be potentially harmful. It's probably worth noting that our understanding is that the alcohol industry representatives also opposed those amendments to the code and weren't supportive of it either.
So they agree with your position?
As we understand it, we have a similar position.
Right. And what about things like reducing advertising through sporting events and things? Have you made any recommendations around that?
I'm not aware of any.
What about volumetric pricing? Has there been any recommendations around that?
So anything to do with taxation is led by Treasury. We would feed in a public health perspective should they be doing any work in that space.
So, okay, so do you directly interact with Treasury at the present time and make recommendations or not?
We have not been interacting with them on this topic in the recent past.
Right.
It tends to, but should it come up, we will be their go-tos, obviously, from a health perspective.
It's not very proactive, if I may suggest.
That's a fair point.
Have you a plan of action now to any further things around marketing and labelling, or not?
So we're looking at the entire drug and alcohol program across the board at the moment. So we're evaluating. We're just gone to market for someone to support us to do an external evaluation of that spend, which would look at what we're spending on treatment and prevention, and make recommendations across best practice, etc. So we're being very proactive in that, and we want to use that as a vehicle to have further conversations.
Yeah. How could we, as a parliament, as politicians, help you in that? Would it help if we made some suggestions in our report that might around the marketing and promotion of alcohol?
And we certainly welcome suggestions from this committee, and we have found the process of the committee and the submissions to it, and actively monitoring the appearances before the committee very helpful for us as well in our work. So you've already contributed in many ways. Suggestions through your report certainly would be welcomed. Of course, any decision is a decision for government, not necessarily a decision for us within the department.
Because we do have some major concerns around the marketing and availability of alcohol, and we do have some concerns about some of the suggestions that Professor Clark has made around younger people with severe alcoholic liver disease presentations and things like that. So
we're also mindful of, while we have a place to play, we're not the only player, and there are many things, particularly in alcohol licensing, etc., that are in the purview of states and territories.
Yeah.
And so it requires action on many parts to the kind of discussions you've had are not something the Commonwealth could take forward alone and make change. Although we have a part to play, I'm not saying we don't.
Within the existing framework.
Yeah. Good. Jenny.
Thank you. Thanks very much for being here today and for your evidence. I've got a few questions. First of all, I note, Ben, that you said that you would send some statistics in. I'm particularly interested in younger people, so 25 to 18, and whether or not statistics bear out some of the. I've heard a bit of conflicting data, and there's a lot of commentary around at the moment that the youth of today, that next generation, are in fact drinking less than generations that have gone by. So I'd be very interested in the stats and the history and what we've got on that particular age group. Also, we heard some very distressing evidence in relation to the fetal alcohol syndrome today. One of the issues that came through was a stigma that is there for both for the birth mother and also for the child, and the child may now be an adult. What relationship does your department have with the education, a federal education framework, and particularly how, for example, are you feeding in assistance and research into the education system to be able to better empower the state education departments to educate teachers and the education system overall about the impacts of fetal alcohol syndrome?
I might take the first question, and we will then answer the second. So trends in risky consumption of alcohol, we have data in our submission from 2010 to 2023, about every 3 years or so. In general, they've been trending down up to 2019. In some cases, they have ticked up since. Now, what has ticked up since is young women in the 20 to 29. So our data is kind of 14 to 19 and 20 to 29. Right. Doesn't quite capture the exact data set you want, but it's probably useful. So 20 to 29 years, risky consumption of alcohol by females, 2010, 48%. Tracked continuously down to 35% in 2019. And then we saw an uptick to 40% in 2023. So still below what we saw in 2010, but a worrying direction.
So what was it in 2023? Did you say 40?
40, yeah. So 48 in 2010, 35 in 2019, 40 in 23. Now for the 14 to 19-year-olds, it has tracked, it's kind of tracked generally down. There was a small blip, but it's 20 to 9 to 8, essentially, over those 3 timeframes. For young men, we see more of a direct line downwards. 20 to 29-year-old men in 2010 were 62% were drinking at risky levels. By 2023, that was 44.9%. And that had been more or less a straight line kind of decrease.
They're pretty high numbers.
Now, by the time you get to older levels, you still look in the 40s down to the 30s. For men, women, it's down in the 20s. Once you hit about 30, you're 26 or lower generally percent.
The young women, the young females in the 14 to 19, those numbers, although they're, there's been that upsurge again. Do you have any research on why it is that younger women are seemingly drinking a lot more, or drinking in a high risk manner?
So this data, I think, was published last year. So it is a little bit early to have kind of research analysis on that. It is certainly something we're discussing with our research partners. And it's something, I've heard it being spoken about to you this morning even. It is in our thinking and the conversation about this in general.
Okay. Thank you for that. And then I think
the education
piece. The education piece, yeah.
And I do think this is a really complex space, and certainly, I caught a little bit of the evidence that was given today and heard the distress in the voice of the witness. In previous experience, I've had the opportunity to visit places in remote communities and seen the efforts of particular communities as they've sought to, I guess, take up the fight, really, and had the opportunity to kind of speak to individuals with lived experience around that. So I will get to your question, but I did just want to note that, one of the complicating factors here is that in some instances we're looking at people with significant underlying traumas and early life traumas that are contributing to risky drinking whilst pregnant. And so these aren't people who are exhibiting a lack of care, they're actually people who have either experienced stigma or trauma, and this is essentially driving self-harming behaviour that then is reinforced because they know that this self-harming behaviour has caused harm to their child. And so that makes it quite a complicated space to address. And so there's a range of investment that we have, and I should say over successive governments, about 97 million, I think, over 8 years since 2018-19 has been spent in FASD, on FASD measures. And it's under the FASD, National FASD Strategic Action Plan, which goes out until 2028. There's 4 national priorities, which are prevention, screening, diagnosis, support and management, and priority groups and populations at increased risk. And they support a range of diagnostic and support services and information and awareness raising activities. So to go to the very heart of your question, which is what do we do with the Department of Education around influencing state education systems, we don't engage directly with the jurisdictions around this. We do fund the University of Sydney to develop a suite of evidence-based resources with the intention of those being able to be provided to educators to guide how they work with students around FASD. So it's probably one step removed from a direct engagement, but it is part of that broader suite of building health literacy so that people, as they approach the age of childbearing, they're in a position to have a greater knowledge of what the risks are. And that is complemented, again, as Ms Clancy was saying, around some of the things that are now in place as mandatory requirements in terms of alcohol labelling around risks to pregnancy, risks to the unborn child. So,
Okay.
And we also have, we've engaged Monash University to progressively update, make living guidelines of the Australian Pregnancy Care Guidelines, which is also in support of this.
I think, and I'm also very interested in how you see that your department could better assist the state departments with assistance in the school system for school students with FASD. We heard. Oh, I'm sorry. Just to give you a bit of context for that, we heard lived experience said that a lot of the symptoms of things like sensory processing, autism spectrum disorder, and a range of other behavioural issues, and that the witnesses said that they did not feel that they were adequately supported, or that their child, depending on which witness it was adequately supported within the education system, because the school system and the teachers, it's no criticism of them, they simply did not understand what FASD was, and then how to provide the supports within the classroom to support those children or those students.
And if you kind of extend that further, we know that education is a key vehicle for social mobility, and how you traverse through that determines what your life trajectory could look like. And for many young people who aren't able to succeed through education, particularly those that have these compounding risk factors, that contact with the criminal justice system is more likely. And so you could have one person who finds their way up into, shall we say, a job in the Department of Health and Aged Care, and another person who ends up in youth detention by virtue of the fact that the system isn't able to cater for those more acute needs that an individual might possess. And that's not strictly limited just to FASD. There are a whole range of developmental issues that I think most schools and teachers aren't necessarily either equipped with the knowledge or have the complementary resources to assist, or access to the complementary resources to assist with probably that more intensive care that those young people might need. The department is providing funding through the Central Australia package of, I think it's about $18.4 million to the Central Australian Aboriginal Congress, which is an Aboriginal community-controlled health organisation. And that's for, the acronym is CYATS, or CYATS, Child Youth Assessment Treatment Service, of which a part of what they do is being able to get earlier diagnoses of FASD, but not FASD alone, but other conditions, developmental conditions, which then put that health provider in a position to actually either make referrals to the services that those young people might need, or to activate the resources that they have within that. So the funding that the Commonwealth has provided enables for them to have occupational therapists employed directly by the provider, speech therapists directly employed, paediatricians, social workers, the sorts of additional supports that could prove to be the difference between somebody slipping through the cracks or somebody sort of being held. Now, that's currently not operating at what you would anywhere near call a systemic level. That's very bespoke funding as part of the Central Australian package. I know that there's an interest in that being rolled out more broadly within the Northern Territory, because other providers are seeing the potential benefits of that, but as far as I'm aware, I'm not sure what that looks like more broadly across other jurisdictions.
Some of the Prime Minister's recent announcement was to increase some funding for early diagnosis.
But that's relating to Indigenous Australians and remote communities and the Northern Territory. My electorate is down in southern Sydney. Does that mean that at the moment that there is nothing being planned, or there is nothing available outside of that funding?
I think we probably have to take on notice whether there's anything available.
Yeah, if you could take that on notice, and also how do you feel that the education system can be better educated as to FASD and to support students with that within the classroom, because one of the evidence that we heard from one of the previous witnesses when I asked a similar question was you've got to educate the educators. So I'm interested in how is the federal department going to assist with that? What's going to be that relationship going forward? So if you could possibly get back to the committee on that would be great. I've got one last question that's oh, sorry, Chair, did you want to go? I was just also interested in the opioid dependence treatment program and the take-home naloxone program and their role in harm reduction. If you could just provide the committee with an update on that.
Yes, we can indeed.
Thank you.
Excuse me while I find this.
Well, why don't you ask your questions? We'll let you do that.
Yeah, it's really just to follow on from Jenny around maternal health and education. I mean, the numbers are really staggering. 40% of women are having unplanned pregnancies. Then we're seeing an uptick in numbers of young women in childbearing age who are drinking. And all of this has been supercharged since the pandemic because online marketing and rapid delivery of alcohol really took off. So we have, I think almost like another tsunami of this is going to hit us at some point. And the testimony from the lived experience lady, her advice, and I think it's very good advice, was we should be thinking of screening these children who are coming into school, the preps, in 2025-26, which brings me to a question around the maternal child health checks. So babies are checked in hospital, paediatrician, out they go, then they're checked by the maternal child health nurses. And I do wonder whether there needs to be, given there may be somewhere between 11 or 12,000 children out there every year with undiagnosed FASD, whether then an early intervention is always the best, right? Whether we need to have a universal screening by maternal child health nurses at maybe 3, 4, 5, something like that, before these children enter school. I agree with Jenny that we do need to educate teachers, but teachers have a lot on their hands, and we can't really expect teachers to pick something as subtle and as challenging as this up, whereas we do have a fantastic network already of maternal child health nurses. Should we be funding or looking at funding health checks a little bit closer to school?
So we have colleagues who work across the screening program. It's probably best if we refer to them and take that one on notice, if you don't mind.
Thank you.
Because we wouldn't have the expertise here. Going back.
But also it's important to note that is probably best done at a state delivery level. Yeah.
Does Commonwealth fund some of the maternal child health stuff?
Another one on notice, I think, for
Okay.
us.
I think we do, Chair. It's a little bit.
If we go back to your question about harm reduction measures, so there's 3 different harm reduction measures we fund nationally. Take home naloxone, so that's 19.6 million over 4 years, plus there was some additional funding in 23-24. So this provides naloxone without the need for prescription to people who may experience or witness an opioid overdose or adverse reaction. So naloxone, if you're familiar with it, is an antagonist which temporarily reverses and blocks the effects of an opioid overdose. It's available nationally from participating community and hospital pharmacies, as well as other sites like drug and alcohol treatment centres, custodial release programs, needle and syringe programs. We have dispensed already supplied, so this was July 22 to December last year, 609,000 units of naloxone have been supplied, and there are at least 5,000 registered providers. 372,000 people could have accessed it between July 22 and December 24. This is an estimate because we don't take data on individuals as they access the programme. So that's one. The second...
Sorry, just on that, so if you're not taking the data, how do you know if the program's working? What measurability have you got?
Robin, is this one that you can help us with?
No, I'm afraid not. The TGA doesn't keep any prescription data such as the use of naloxone, I'm afraid. Sorry.
But do you keep any data on the numbers that are dispensed?
Yes, so we do that. It's not identifying information that we capture. So, you know, the extent to which we have somebody coming back and coming back and coming back, we're not collecting that unit level data. It's the number of units that have been dispensed.
And we can come back to you on... We have looked at the effectiveness of the programme. We can come back to you on that.
Yeah, okay. No, if you can, I'm just $19.6 million, and it's. I mean, opioid dependence is becoming an increasingly important and worrying addiction and a worrying health issue. So you're not able to give me any or give the committee any more information about the program, except that data doesn't seem to be being collected.
Data is being collected on quantities supplied.
Quantities supplied,
but not to whom, which is a privacy issue around making this accessible to people.
And then how is success or otherwise of the program being measured? Like
there has been an evaluation, and we'll be able to get you information on that. Yes.
All right. So particularly if we can look at if the information is there as to where the money has been spent, how many previously dependent patients have been able to recover from that dependence.
So naloxone, I think, is more about an incident rather than a kind of treatment and cure per se.
Overdoses. I know that that's about overdoses, but in your opioid dependence treatment program, there's something more than just take home naloxone, because it's a completely separate program.
So this is a second program I can talk to you about now.
Could you take that on notice, because we are running out of time, I'm sorry. Yeah. Is that all right, Jen?
Yes.
Yeah,
that's fine.
If you don't mind
so
taking
we'll
that
get back to you on the opioid dependence program as well. No problem at all.
Thank you.
Great. Thank you for coming today. If you've been asked to provide any additional information, please forward it to the Secretariat by Friday the 14th of February 2025. You'll be sent a transcript of your evidence and have an opportunity to request corrections to any transcription errors. And once again, thanks for giving us your valuable time.
Thank you very much.
Thanks.
Appreciate the opportunity.
Great. So I declare reopen this public hearing being held in Canberra of the House Standing Committee on Health, Aged Care and Sport for the inquiry into health impacts of alcohol and other drugs. I remind all those present that as Chair I'll ensure the proceedings are conducted in an orderly, respectful and courteous way in accordance with the Committee's resolution of the 4th of August 2022. This hearing will be broadcast on the Parliament's website and the proof and official transcripts of the proceedings will be published on the Parliament's website. I now welcome the witnesses from the Federal Department of Health and Aged Care, from the Federal Department of Education to give evidence today. And for the Hansard record, would you please state your name and the capacity in which you appear before the committee?
Thank you, Chair. I'm Pamela Banerjee, Assistant Secretary, Wellbeing and Equity Branch.
And Paula Sheen, Acting Assistant Secretary of the Inclusion and Disability Branch.
This hearing is a legal proceeding of the Parliament. The giving of false or misleading evidence is a serious matter and may be regarded as a contempt of the Parliament. The evidence given today will be recorded by Hansard and attracts parliamentary privilege. I now invite you to make a short opening statement before we proceed to discussion. Thank you.
We didn't have an opening statement, so we are happy to take questions. So.
Okay.
No, we didn't have anything additional to add to the submission.
To the submission, yep. Good. Well, we might start with questions. I might kick off. Does the Federal Department of Health keep any data about the effects of drug and alcohol problems on the national education system?
Do you want me to?
Yeah.
Thanks, Chair. We don't keep specific details about the effects of drug and alcohol on the student population. What we do have is a nationally consistent data set that is around adjustments made for children with disability. So the children are impacted by drug and alcohol that have a disability needing an adjustment in the classroom would be picked up in that, but not on a specific basis on what's causing the disability.
Right. So, in fact, it's very difficult for you to give us any idea about problems like fetal alcohol syndrome and incidents in the class or number of kids affected?
That's right. We don't have that level of detail in the Commonwealth Department.
Right. Do you have any details about areas that may be under federal government jurisdiction, like in some of the territories and some of the Indigenous communities? Or
no.
So, Chair, as I'm sure you're aware, the Federal Department of Education, we obviously work on setting the national education priority policies. Mm-hmm. We obviously provide amounts of funding for school education, but in terms of the day-to-day operation of education, kind of in the school setting, it's undertaken in the government sector by state and territory departments of education and the non-government school authorities.
Right.
So in relation to the local arrangements and information around what's happening at a local school level, that would be the state and territory governments or the non-government education authorities. Yeah.
Yeah. Do you do any work around national programs for example, fetal alcohol syndrome?
I can't comment on specifically on fetal alcohol syndrome, but we do a range of things around student well-being and learning outcomes. Mm-hmm. So, for example, we have a range of programs that we focus on, student mental health and well-being. So to make sure that they are engaging in classroom learning, the learning outcomes are kind of happening as expected. Yeah. We work with states and territories and the non-government sector in implementing those programs. We also have the national curriculum, which looks at the classroom teachings in relation to, raising children's awareness and their behaviours in relation to, and it's from foundation to year 10, age appropriate in terms of how they react to you taking up, say, smoking or alcohol in the later years. So kind of giving them that early education and intervention. But as I said, the national curriculum is set by, or rather, it's a national curriculum. How it's operated at the classroom level or at the state and territory level is determined by the states and territories. Yeah.
And do you have a specific alcohol program?
So within the curriculum, there is the health and physical education. Sorry, I'm just referring to my notes here. Health and physical education elements within the Australian curriculum.
Yeah.
In that HPE, as we call it, HPE curriculum, we have there's a focus on personal, social, and community health, which focuses on knowledge, understanding, and skills that students need to make healthy and safe choices. And then the other aspects within the curriculum is in relation to movement and physical activity. The HPE learning area also includes a focus on alcohol and other drugs, which aims to inform students about the importance of safe practices in relation to range of drugs, including alcohol, so that they can make informed decisions regarding their bodies.
Right.
And as I said, it's age appropriate, so it goes from foundation year to year 10, so it's incremental.
But I'm not sure how it works. What you deliver this program to the state?
So it's the curriculum is what is taught in the classroom by teachers.
Yes.
The national curriculum sets the parameters. States and territories and non-government authorities then use that to determine what will be delivered in classrooms. So how it is delivered in a school setting is up to states and territories.
So you deliver that to each department in the state, and then they determine how it's used. You don't actually deliver it to...
We don't deliver it, no.
No.
I mean, the curriculum is set at the national level, but how it's interpreted and used and how kids are taught in the classroom is up to the state and territory education departments.
And do you have oversight of that to make sure that it is delivered appropriately?
I will take that on notice in terms of what level of oversight we have, because as you would be aware, the curriculum is managed and maintained by ACARA, which is the National Curriculum Authority.
We've heard lived experience evidence today that basically lots of kids with fetal alcohol syndrome are being missed, they're not being picked up. Even when they are picked up, they're not being given support they need. There's very little education in terms of the risks of fetal alcohol syndrome to kids in the teenage years. I'm just wondering how we can get better oversight of that, and whether you have any mechanism that you know of where that is looked at.
So I think my understanding is what you're asking is in terms of kids with FASD, if they are getting picked up and screened in terms of their learning.
And given support they need, and as to whether there is an education program about the risks of alcohol consumption delivered to kids in school.
The education program in terms of the alcohol consumption delivered to kids would be for children to learn in the classroom in terms of the harms of alcohol and drugs. And that's part of the curriculum learning, which, as I said, we have the national curriculum, but how it's taught in the classroom is up to states and territories and non-government authorities. In terms of kids getting picked up.
Sorry, could I just...
sorry,
I think it's just... I'm not trying to say that I understand what Mike's asking, but the chair's asking, but...
You're welcome to interpret.
Yes, sorry, yes. So
that
means that... So do you have confidence that every state is implementing those lessons around the risk of drinking alcohol in pregnancy, for example?
I think we have a certain level of confidence that the HPE curriculum is being taught in classrooms.
A certain level of confidence. So how does it work in terms of how do the states come back to you, your federal, and demonstrate that they are complying with the curriculum issues, the curriculum content that you're setting?
So I think I'll have to take that note on notice and kind of come back to you, because I don't think as a department we have, ACARA would have visibility in terms of if there is any. I don't think we collect that information directly from states and territories, so we will have to provide some more information to you in relation to how, if ACARA has any visibility of in that regard.
Okay, so could I maybe make it a little bit easier? The Commonwealth, the department sets, for example, the English curriculum. The states are obliged, as I understand it, to carry out to implement the curriculum on English. How does the federal department know that the state departments are actually doing that?
As I said, I think we are kind of, as you would know, that the Curriculum Authority is an independent kind of authority, so we will have to reach out to the ACARA to get that information and provide you. I don't have that information available with me at this point in time.
Okay, yeah, if you could please respond
That would be
on
good,
that.
yeah.
That'd be good. So, and you have no, so there's, I think that there's that curriculum issue about teaching about AOD. Then there's the other issue, which is the support for students that have AOD, because as Mike said, we heard today lived experience that said that there was no support.
I can talk to you.
Thank you.
So under the Disability Standards for Education, the subordinate legislation under the Disability Discrimination Act, all schools are required to make reasonable adjustments for children with disability if they need it for their educational purposes. Children with FASD or similar conditions would likely fall under that, where they need that extra support. So that's an obligation on schools and obviously the authorities as well. Within that, what the Commonwealth Department of Education is doing to support that is to provide resources for students and their families and carers to understand those rights and advocate and work with the schools around consultation on what reasonable adjustments would be, and also some resources for the teaching and leadership of schools around how to implement that in the best practice. So they're the ways that the Commonwealth can lean in and support that, but the Disability Standards for Education is an obligation on all education providers to make adjustments so children can participate and learn on the same basis of their peers.
But we heard evidence today that that's simply not being done. So what's a sort of a recommendation would you see that could be put so that the framework that you've operated on and that sort of philosophical statement or the motherhood statement at the top is actually being carried out?
So often if we get messages about individual cases, we will suggest working solidly with the schools, see whether there's anything missing in those communications and consultations. Then the next step would be to work with the State and Territory Authority, who governs all the schools. But then if people want to write to the Commonwealth Department of Education, we can also see if there's anything there, and that might inform policies and resources and so forth, if there's a specific thing around fetal alcohol syndrome that we can do.
Thank you for that. My experience as an MP is that parents, for example, who are struggling with something that's going on within the school system, and particularly if they've got a child with developmental delays or educational, some sort of disabilities, one of the last things that they're going to be thinking about is writing to the Federal Department of Education on a case-by-case sort of basis. Could you provide sort of a recommendation about how FASD can be better incorporated into schools, and education around FASD can be better incorporated as a policy issue so that these children are not slipping, or the students are not slipping through the net as they currently are?
I think accessing the resources is a good place to start. They do, so it won't be disease specific at the moment. It will be around an individual's child's needs for adjustments and supports. I think that's a good place to start, but we are happy to think about if there's anything specific on the topic that could be weaved into resources going forward that might help both the teaching side of things and the families to have those connections and discussions.
If you're able to be really helpful, if that can be put back to us in writing, that's all, because with all respect, I don't think just dealing with it as waiting for a parent to contact a department is the way to go. I think that it's a matter for the department, the federal department, to work first of all with health to say this is a a clear disability. It's really, and it's not being picked up in the normal way in the classroom to assist these students. So I think there has to be, first of all, the communication between federal health and federal education, and then, or the collaboration, and then that needs to be fed down into the state education departments, and then there needs to be some final, accountability on the part of the state department, the departments of education, as to how that's been, as to whether or not it is actually being implemented. I mean, do you have those sorts of figures on something like autism spectrum disorder?
Again, we don't collect the disease element of information. We collect information about how many children needed a reasonable adjustment in the classroom and the different categories of that. So to get a reasonable adjustment, you don't need a diagnosis of any sort. You just need for the profession to recognise and put reasonable adjustments in place. As Pamela suggested earlier, or mentioned earlier, so state and territories would likely collect that level of information. We don't have it in the department, the Commonwealth Department of Education.
Okay, it's been my lived experience that is simply, it's not being, that's not the way it's working in theory in the classrooms and in the schools. Certainly that's been my experience in a couple of schools in New South Wales. And certainly that's what comes to me all the time from parents with children, so children with disabilities. So yeah, look, thank you. If you can provide that additional information, that will be great.
Yeah.
I've got to go, and I'll be back just after 1:30.
Sure. Thanks, Jenny. Yeah, I mean, our concerns are that the Federal Department of Health gave us similar sort of answers, which we get, but the families are telling us that the recommendations that were made by the peak FASD organisation some years ago have not been implemented, that there's still large delays in diagnosis, delays in getting support into schools for kids and for early intervention, and that we need to have a national program and some ability to make sure that the recommendations are implemented. Has that come across your desk before about FASD, or no?
Not in my time there.
Right.
In saying that, we do work with our Department of Health colleagues for a range of, other things that we have recently implemented. For example, the vaping reforms that you would have seen. Department of Health has been leading those reforms, and we have been working with them in terms of how it's implemented across the education sector. So the education ministers as well as the health ministers have worked together on that across all jurisdictions and the Commonwealth. So we would definitely be more than welcome an opportunity to work with Department of Health on the FASD side of things as well. So.
Good. Well, I'm sure that will be one of our recommendations, but it was quite distressing today to hear some of the I don't know if you saw some of it, some of the lived experience. It was pretty sad. I've got a couple of other questions, but I'll pass over to Monique. Now, Monique, have you got some questions?
I have, Chair. Thank you so much. I think I was missing something. Apologies if that was the case, but you were speaking to the fact that you've got requirements of schools in terms of the services that they should supply to their students, and you provide funding to assist with the provision of those services. But was I wrong in hearing you say that you don't then circle back to measure or ascertain the effectiveness of those interventions?
So, Dr. Ryan, I think what we were talking about earlier was in relation to the national curriculum for health and physical education. So, as you know, there is obviously the national curriculum that schools deliver, but how the curriculum is delivered in classrooms is up to the state and territory education authorities as well as the non-government education authorities. As a Commonwealth Department of Education, we don't have visibility of the classroom delivery as much as perhaps the curriculum authority, where we have taken that on notice to kind of circle back in relation to if ACARA is able to provide more insights into that.
Right. So you don't directly measure the effectiveness of the interventions that you require from schools?
So these are not interventions, Dr. Ryan. It's mostly obviously what is taught in classroom on a day-to-day curriculum of the health and physical education kind of learnings and teachings that the kids learn in school. So it's part and parcel of their everyday learning and going to school. In terms of other programs that we have, so we have a National Student Wellbeing Program that provides funding to states and territories to deliver wellbeing supports to schools. We do have reporting arrangements between the Commonwealth and states and territories in relation to what that program is delivering, but that program is broader than just alcohol and drugs. It's more about student wellbeing, providing pastoral care, providing student wellbeing officer positions in schools. So that's kind of a broader program, but in relation to those specific programs, we have reporting arrangements with states and territories and non-government school sectors, but in relation to the classroom delivery of the curriculum, there are no reporting requirements as such between the Australian government and education authorities.
So you don't actually know if they're delivering that service at all?
As I said, look, I can't specifically comment on what we know at this stage because I don't have that information with me. As I said, we will come back to the committee with more information on classroom delivery of the curriculum.
Okay. It's sort of hard to know what to ask because it seems like it beggars belief that you provide fundings and expectations to the state governments and you don't, it would appear that you're not really sure whether or not you deliver those services and if you do deliver those services, whether they're effective.
As I said, Dr. Ryan, I think what I was talking about in terms of the curriculum was the classroom delivery of kind of lessons around, what kids learn as part of their curriculum. They're not intervention services as such. But as I said, there are other programs that we fund where we have reporting arrangements and we know what's going on in relation to their delivery.
Okay. Thank you, Chair. I don't have any more questions.
Thanks, Vinay. Can you give us an example of some of the programs that you've delivered?
So, as I said, one of them is the National Student Wellbeing Program. It's, I think, 61.4 million a year. We have that funding arrangement with states and territories through a federation funding agreement.
Yeah.
That program allows, within the program, schools are able to employ either a school chaplain or a wellbeing officer to kind of support students with wellbeing needs and also look at whole of school approaches in terms of school wellbeing, student wellbeing within the school. Through the Federation funding agreement, we provide that funding to states and territories then have an application-based process where schools apply for that funding to their respective education departments and they get that funding.
And you track that?
Yeah. So we have a reporting arrangement with states and territories where we get annual reports from states and territory education departments in terms of, how that money is spent, how many schools are, using it.
And how many use a chaplain, how many get just a welfare officer?
Yes. We, this is the first year so 2024 was the first year where the schools had an option of either a chaplain or a wellbeing officer. Mm-hmm. So that report, 2024 annual report is just coming into the department now. So we are going through that assessment process in terms of to see, what the reports are telling us.
And do they get involved in drug and alcohol?
They would, and the design of the program is such that that the chaplains or the wellbeing officer, the school actually determines what is needed within the school, within that particular school community. So if there is an alcohol and drug issue that has been identified by the school and the school would like the chaplain or the student wellbeing officer to address that, I'm sure they would be looking into that, but we give enough flexibility within the program so that it's up to the school to decide how that resource is used. Yeah.
But they don't report directly back to you, they report back to the
states and territories. Yeah, that's
okay.
correct.
Good. All right. Are you aware of any trends in drug and alcohol problems being reported in schools? Do you look at that sort of information?
We don't collect that information, Chair. So yeah, I would not be able to comment on that.
Good. Okay. Well, I don't have any further questions. So thank you so much for coming along today. If you've been asked to provide any additional information, I think you have, please forward it to the Secretariat by Friday the 14th of February 2025. You'll be sent a transcript of your evidence and will have an opportunity to request any corrections to transcription errors. And once again, thanks very much for attending.
Thank you so much.
So, welcome. Thanks for coming along today. I now welcome the witnesses from the Australian Federal Police to give evidence today. And once again, thanks for giving us your time. For the Hansard record, would you please state your name and the capacity in which you appear before the committee?
Adam Rice, Acting Assistant Commissioner for Crime Command, Australian Federal Police.
And I'm Commander Paula Hudson of our Transnational Serious Organised Crime Command.
Great. Well, thank you for coming. This hearing is a legal proceeding of the Parliament. The giving of false or misleading evidence is a serious matter and may be regarded as a contempt of the Parliament. The evidence given today will be recorded by Hansard and attracts parliamentary privilege. I now invite you to make a short opening statement before we proceed to discussion. I'm Mike Freelander. I'm the member for Macarthur, which is in outer southwestern Sydney. On video we have Monique Ryan, who's the member for Kooyong in Victoria.
Thank you.
Thank you.
Good morning, Chair and committee members. Thank you for the opportunity to appear today. I will just make a short opening statement if I can. Firstly, I would just like to show my respect and acknowledge the traditional custodians of the land in which we meet today and pay my respects to elders past, present and emerging, and particularly to those Aboriginal and Torres Strait Islanders who may be present. Thank you. The AFP is committed to protecting Australia's lives, livelihoods and Australia's way of life. We know that criminals go to extreme lengths, often risking their own lives, to smuggle drugs into Australia with little to no regard for the cause to Australian communities. We play a key role in the prevention of illicit drug-related harms under the current National Drug Strategy through our supply reduction efforts. The AFP prioritises offshore disruption, detection and deterrence where possible to stop illicit drugs at their source of origin or transit point and before they become a cause of harm to the Australian community. In 2023-24, the AFP seized 34 tonnes of illicit drugs and precursors, resulting in an estimated $12.5 billion worth of harm being removed from the Australian community. A further 36.5 tonnes were seized overseas by police with assistance of AFP. The AFP recognises the importance of collaboration in this complex This is a complex issue related to drug use. Our partnerships with local, state and international law enforcement agencies are integral to tackling this problem. The global nature of the drug trade requires a united response through joint investigations like Operation Ironside. We continue to strengthen international cooperation to disrupt the drug trafficking routes and transnational serious and organised crime groups. The coordinated effort extends beyond into the private sector, where we work with transport companies, logistics companies and other key partners to disrupt the movement of illicit substances into Australia. The success of these partnerships highlights our commitment to safeguarding Australian communities from the harmful effects of the illicit drug trade. Additionally, the AFP remains focused on enhancing our technological capabilities to stay ahead of increasingly sophisticated methods used by drug traffickers. With the rapid advancement of technology, transnational crime syndicates are finding new ways to smuggle drugs into Australia, often using encrypted communication channels and covert shipping methods. To counter these efforts, the AFP has invested in state-of-the-art surveillance systems, intelligence sharing networks and advanced forensic techniques to detect and dismantle these criminal enterprises. Through strategic use of technology, the AFP ensure that we remain at the forefront of global efforts to combat drug trafficking and protect Australian society. And lastly, that social media has provided a very powerful tool for raising awareness and driving community engagement in our ongoing efforts to reduce demand and minimise harm. Through various platforms, the AFP is able to directly reach a wide audience, providing critical information on drug use, the risks, as well as updates on law enforcement activity and significant drug seizures as they occur. These campaigns also serve as a reminder of the potential harms that illicit substances pose to individual communities to the individuals and communities. By using social media to connect with the public, the AFP not only educates but fosters collective responsibility for reduced impact of drugs in our society. Thank you, Chair, and welcome your questions.
Thank you. Well, I might start with a couple. And thank you for the work that you do. I think it's incredibly important work, particularly as a paediatrician. I don't want my young patients exposed to the risk of illicit drugs. And I'm aware that increasingly sophisticated organisations are involved in bringing them into Australia. But I'm just interested in your interaction with the Department of Health about new trends in drugs that are being used, and whether you do liaise with the Department of Health. Maybe could you comment on that at all?
I certainly can, and I'll also ask my colleague to step in where with more subject matter expertise as required. We do constantly monitor trends, obviously, through the drug trade, including with all Commonwealth agencies that have a footprint in that space, and particularly with ABF, but also with the Department of Health as needed.
Yeah. And how do you interact with the state police forces? Do you have regular set meetings about what they're finding in the individual states on the ground? Or
I do. I will just start with a brief comment and I'll pass to my colleague to give the detail, but there's a raft of national and state coordination meetings that occur in this space where we often talk trends and all things related to importation, etc., of drugs. Perhaps for more detail, I'll pass to Paula for the structure.
Yeah, and just to touch back to your question, Chair, around the Department of Health, I think a good example to, I guess, show you the practical application of how we do that is the recent, particularly in 2024, we saw an increase in synthetic opioids, and particularly a substance called nitazines, which is a completely illegal pharmaceutical that went wrong back in the 50s. However, we really rapidly gripped that up with all the jurisdictional health departments who, were flooding the communities with warnings that was obviously materialising through, festivals or just local hospitalisation presentations. So quickly we gripped that up and formed, national roundtables to address what we were going to do in respect of this new emerging trend. But we take that advice immediately from those jurisdictional health departments, and that really informed our Commonwealth position in relation to defending the Australians from this new emerging drug trend, which we have really seen no detections since October last year. But we really launched on that strong public messaging campaign, around safety and knowledge is that first line of defence when it comes to these really dangerous trends. But that was a direct result of health departments around the jurisdictions raising the alarm from hospital presentations.
Yeah. And do you think some of the health policies that we've instituted in the last few years, like reducing amounts available on prescription, for example, for opioids and some of the previously across-the-counter medications, do you think that's helped at all? The public health policy?
Yeah, probably not a space really for me to weigh into on that one. So not really seeing any, increased trends and impacts from that as yet that's notable to sort of comment on.
Right.
But I guess just going to your question around the state and territory policing engagement that we have, we've got formal arrangements through, joint what we call JOCTIF or Joint Organised Crime Task Forces in most of our jurisdictions now, or actually in all the jurisdictions we have joint task force arrangements. So that's that, if we need that domestic response, we have those arrangements, but then we have another more formal architecture that sits over the top through serious organised crime committees, and then we have sub-working groups under those at lower levels. So sort of all at the operational level of police, we have the task forces, and then at the management structures, we have various committees that sit over top to really formalise those working arrangements.
So it's much more formal and collegiate than it used to be. My brother-in-law worked in the New South Wales drug squad for over 20 years. So, it was probably less cooperative in those days. Yeah. Are you responsible for continually informing the federal ministry about the sort of trends, or do you have a formal meeting with the government at any stage?
I guess another highlight to pivot back to the example around particularly the opioid, fentanyl and nitazene. We work together at the Commonwealth level with Australian Institute of Criminology about informing the Attorney General's Department around the legislative gaps that we were seeing with these, as the organised crime continue to produce, they change the chemical construct to get around the legislation.
Yeah.
So an example of that recently, through advice and working together with Attorney Generals, we were able to get some legislative reform with up to 45 new variants of nitazene and fentanyl listed. And that legislation that was scheduled, as part of the Drugs Control Act, and that comes into place on the 1st of March. So that's how we do work in with the government to assist and inform.
Good. And for the general public, they are very sensitive to what's happening on the street in their own neighbourhoods and things like that. Can you make any comment about the trends in terms of seizures of things like amphetamines and opioids, about whether we're doing well or not so well, and whether you need more resources? Can you make some comment about that?
I think we're still seeing significant importations of all of those drugs that you mentioned there in volume and tonnage of those volumes. So I think we continue to work hard on, as we said, disrupting those offshore before they come into the domestic system. And then we work very closely with our state and territory partners at a more domestic level. That more street level interaction, if you like, is perhaps a state and territory responsibility more so than talking at a Commonwealth level, where we're trying to, as I said, disrupt offshore and stop that downstream effect.
Yeah. And I know there have been recent concerns about different pathways of these drugs getting into Australia, particularly through some of the Pacific Islands. Is that an issue?
Yeah, it is certainly. I'll certainly hand over to my colleague for some detail around that, but certainly that's an area of drug trafficking, the route that we are certainly looking into in more detail through the Pacific.
Yeah, I guess the common ways of obviously being an island nation that we are, the only ways to get these substances or border controlled drugs to Australia is maritime and the airstream, and then obviously cargo facilities. So they're the three big ones for us. But what you pointed out, Chair, on the Pacific Islands, maritime is one of our biggest threats. It is the way in which organised crime targets Australia, because they can get it in on the tonnages. Yeah. So volume perspective, and obviously our large borders. So that is certainly really at the forefront of our minds. And when we talk about maritime, ventures, we have a really good apparatus. We work with Border Force and the Defence Force through the Maritime Border Command apparatus, which is actually based here in Canberra. But that's a data machine that works to protect the borders and looks at those vulnerabilities, whether it's through the Pacific, those ventures coming through Pacific, or whether they're coming from Southeast Asia. So it's certainly, one of the major areas of focus for us.
Yeah. And you've mentioned, the technology's changing. Do you have enough resources in that space to one of the things, or there are some new developments that you think we should be looking at?
Well, I think we're always looking at new technology advances, and some of those things are not necessarily resources in physical resource requirements, but just technology advancements through ICT infrastructure. I think we're continually looking at that, and we're certainly getting the assistance we need to push forward in those areas, and we're making good investments in those areas. Yeah.
Mm-hmm. Okay, I've got a couple more questions. I'll hand over to Monique Ryan first. Monique?
Thank you very much. I was wondering if I could, and thank you for the work that you do, I really appreciate it. I was wondering if I could touch on vaping and the situation with illicit vapes being brought into the country at the moment, which is obviously front of mind for many Australians. Do you feel that, can you give us your feedback on your interactions with the state-based police forces and how you feel things are going with your attempts to stem the flow of illicit vapes into Australia at the moment?
I would say that, we obviously have close liaison with the states and territories, but probably Australian Border Force is the lead agency in respect to the curbing the import of vapes, etc., into the country. Where those intersections hit with transnational serious organised crime groups that are involved in that importation, then they will certainly become involved in that. But it's perhaps a better question forged for the Australian Border Force to answer that particular question.
Yeah, fair enough. One of the concerns we have about, I guess, drug-related harm is how we communicate it to the public, and the need to avoid glamorising it, I guess, to some extent, while still trying to bring people on board with to understand the potential harms. You mentioned your social media engagement. Can you speak to that helps in addressing or changing the acceptability of illicit drug use, especially for young people?
I think as far as acceptability, I don't think that's certainly not the increase its acceptability. I think it's an awareness piece.
No, I mean to decrease.
Sorry. To certainly raising, as my colleague stated, particularly of recent times with nitazines as such an insidious drug, such small quantities, so fatal in some respects. I think so. Social media played a key role in pushing out that messaging and getting it out to the cohort out there. And I think it's perhaps how we interact with the younger generation, and how we, not just younger generation, but how we target specific age groups within the demographic is important, and that needs to be in